morning, everyone. Good morning, esteemed guests, colleagues, seniors, and distinguished faculty. I am Dr. Avichna Takshak. I am an consultant interventional radiology at Akash Healthcare, Delhi. So it's a proud privilege to welcome you all to day one of ISSVIR 2026, the annual conference. And we kick off this conference with a powerhouse session on aortic interventions. It is my personal passion as an endovascular specialist dedicated to mastering these life-saving procedures. For this session, ladies and gentlemen, it is an honor to have with us our distinguished chairpersons, Dr. Rajesh Bhatt sir. He's a senior consultant at Interventional Radiology Department in Dundee, Scotland, all the way from Scotland. Dr. Vimal Someshwar sir, he's a senior consultant and head of Interventional Radiology Department at KEM Mumbai, Kokilaben Hospital. And Dr. Anil Kumar sir, he's an additional professor at SGPGI Lucknow. And Dr. Hemant Deshmukh sir, he is the senior consultant at Interventional Radiology Department. So for this powerhouse session, we'll start with our first talk. I request the AV team to kindly show the first speaker slide. We begin with the first talk on evaluation of aortic aneurysm treatment, the current best practices. I request the chairpersons to kindly introduce our first speaker.
Hi, can you hear me? Good morning all. Welcome to this exciting session on something that is very close to my heart, that's treatment of the aortic problems. I welcome Dr. Bashi. He's a household name in the world of surgery, vascular surgery, cardiac surgery, and aortic disease. He's a senior consultant and professor in Chennai. I welcome him to give his first talk. Thank you.
Thank you, Rajesh, for the kind introduction. Good morning, everybody. At the outset, I'm thankful to the ISIVR and Dr. Murali, my colleague, for 15 years now, maybe 20 years, not for allowing me to give a lecture today. I look around, I am the only surgeon in this audience, I think, so I can boldly talk what I want. Nobody is going to question me. So when I was looking at the evolution of aortic, given the topic, I thought, whatever is in the literature, everybody can read. So I thought I will take through how I started in this country in aortic surgery and how I progressed and what you people have contributed towards the development of and treatment of aortic surgery to make it safer. Even though aortic aneurysms were present thousands of years ago, in the last 200 years only it started. Initially people started ligating the aneurysm, then Hunter's ligation and aneurysmography. And in the 1950s, once the vascular graft was made by Dr. DeBakey, along with the engineer, textile engineer, only the real revolution in aortic surgery, and Denton Cooley has really done most of the aortic work along with DeBakey. So my journey started in Trivandrum Medical College when I joined in 1977 as a registrar in general surgery, almost same day, January 8th, 49 years ago. This was the procedure I first assisted, that is to do a translumbar aortogram. We puncture the needle and see whether the needle is moving. Then we know we have touched the aorta, and serial changers used to detect, and then serial changing x-rays we used to take. And I have assisted a few of the cases. We will be operating from morning until evening. And we never had a good graft, which most of them were porous. Proline was not available those days. We used to use silk for suturing. And one thing I learned, I came to CMC Vellore for my training in cardiac surgery in 80. We used to do adult ductus by cross-clamping the aorta. That I learned the 20 minutes of cross-clamping and normothermia will not do anything to the spinal cord, not to the kidneys. I don't think many of the youngsters may not know about. They are worried about when the aorta is cross-clamped in aortic surgery. 20 minutes, after 22 minutes, we have published about 135 cases of adult ductus without any spinal cord injury. And then infrarenal aneurysms, blood was a big problem. So we did a study also in Vellore that you set up a cardiotomy reservoir and heparinize the patient, suck the blood and give it back through the femoral vein so that blood loss is reduced. Now grafts were available which are porous, all of them are porous. We used to bake, before heparinization, put blood in the graft and then bake it for 15 minutes and then bring it back. It looks like black color. Then you have to wash the graft and then do Bental's operation. And I did my first aneurysm surgery was ligation of an internal iliac artery. Same thing was done by, on the right hand side of the picture, you see those days no CT aortogram. Murali has done a coiling and a stent graft for that, made it very simple. So first case came aneurysm, huge aneurysm, an old fellow. My boss asked me, can you do something? I said, I have not done anything, sir, but I will ligate it. So I did the operation which was done maybe 100 years ago. That was the introduction. Then I did the first thoracoabdominal aneurysm repair successfully in CMC. That slide is ulta. Patient had absent right kidney, so it was easy. I called the nephrologist to help me to expose the renal artery, and then patient had a stormy post-operative period, went home and lived for 15 years. Came to Vijaya Hospital, where at that time Triple M was functioning there. Large varieties of aortic cases. Nobody was to do the case. We had so many patients coming from all over the neighboring countries, especially African countries with aortic problem. And I did the first successful classical elephant trunk in 1993. Patient had a root aneurysm with a arch and descending aorta in 2 stages we did. Then the first successful total thoracic aortic replacement on a non-sister ride in 94. And you can see the aortogram after 30 years to show how a direct surgery is a long-term follow-up. The graft is lying without any problem. She died about 6 months ago. She used to inaugurate all our meetings. Then I go to another private hospital where you can see, so this is the only setup. We had 2 ventilators, 2 monitors, and there is a split air conditioning there. So total circulatory arrest, cooling the patient was a big problem. We have to put ice because there is no way room temperature will come down below 24 degrees. So there we did a few aneurysms also. This that is not working. And then many of you would have attended our meetings. Started with an international meeting with 1 day with the 20 delegates only, and 1 national faculty, 1 international faculty. So we developed this meeting into a bigger meeting, and over the years we have conducted almost 11 meetings. Initially started with annual, then we made bi-annual because not enough material to conduct the meeting. And most of the who is who in aortic surgery and interventions have come to give lectures, live demonstrations, and most of the surgical faculty used to tell me we have learned a lot, and because of that, lot of complex aortic surgery, I am very proud to say that being done in our country. And even now, I always answers, their doubts in the middle of the night. I have told everybody, any doubt, anytime, you can contact me in the interest of the patient. My wife used to ask me, whom are you teaching at the midnight at 1 o'clock? Steps of operation, where to cannulate, what suture to use, which way to, how much to cool. But patiently she used to make fun of me. You're still like a school teacher, you're teaching. Now coming to the different areas of the aorta, I go through the surgery and the interventional now. Aortic root replacement, of course, open root replacement was a very big operation 25, 30 years ago. Even now it's a big operation, but the results have improved. I've done personally more than about 700 aortic roots, and the current mortality is same as the aortic valve replacement, around 1%. So now aortic valve repairs also being done more. And now, see now the interventional thing, aortic root is being done endovascular, that's a report. Just want to, I'm sure all of you are aware of that and looking forward to doing it, but I think it has got error. I won't say any new invention will have some, of course, it has to be judiciously used. Nowadays the trend is to get something and to want to know who is doing the first rather than trying to do what is best for the patient. That is a very important thing I think I have to make a remark. Now, aortic arch, of course, Surgical treatment is the standard treatment, and different types of techniques like peninsular anastomosis and a patch, individual graft you can see. And these are the some of the cases which I have done a large number, but you can see all these aneurysms are done a single stage, like a midline and a lateral thoracotomy with a good results. And this is a patient who had, I have done only one case in my whole career, Carter syndrome, situs inversus with dextrocardia. Yeah. We operated that patient successfully. Now coming to, I'm sure, a lot of speakers are coming for the hybrid. I just want to show a few of the cases which we have been doing for almost 20 years. And hybrid case, we have followed up almost about 18, we published about 50 cases about 5 years ago of the results of them. These are all simple cases, type 1 without stenotomy. And with stenotomy, in older people who are not fit for surgery, it's a good technique. The longest surviving patient with the hybrid is about 17 years follow-up actually. This patient had a functioning mammary, post-op CABG. He was a doctor. Actually, we had done a carotid subclavian and did a total endovascular. And type B dissection in a patient who had a renal transplant. You can see the kidney in the left-hand slide. And because of her transplant, we didn't want to put her on cardiopulmonary bypass. We did a hybrid. And when this is also another patient with a Y graft with a nowadays we do mini stenotomy. You can see the ascending aorta was a bit dilated, so we just wrapped it to reduce the diameter of the aorta in this particular case. But when the aorta is dilated, now when the patient can undergo cardiopulmonary bypass, I always prefer to do a short cardiopulmonary bypass, cardioplegia, and interpose a graft and then land the graft into the synthetic graft into the ascending aorta, so that the problem of retrograde dissection, which is a disastrous problem, can be avoided. Just a few cases of which we have done type 2 hybrid repair. There is a patient who came with a leaking, actually it's a Marfan syndrome patient leaking, type B dissection. We did an emergency graft replacement. She is afterwards underwent a distal aortic replacement. Now type 3, open antegrade deployment. First we do on circulatory arrest, antegrade. This was, we used to do a good number of cases when this, the FET graft was not available. Nowadays we don't do this, we do most of it is by the FET graft only. And we don't have a hybrid theater, so we have taken the radiolucent operating table and a fluoroscopy machine. Murali is the one who does all the, initially to pass the guide wire in the true lumen. This patient, you can see a huge graft in the descending aorta. After he deployed the first graft, we came off bypass. The false lumen was high pressure. So through the side arm of the graft, we deployed another graft. And these are the few cases of antegrade before the FET graft. It is a difficult thing because we have to do the suturing. The deployment has to be right at the zone 3. If it goes down, it's very difficult to suture the graft. It can produce a lot of bleeding. So Murali is very accurate in placing that graft in the proper place. It's very important. Of course, now we have come into the hybrid processes. The Thoraflex hybrid is a very user-friendly graft. And in this case also, dissections, we always pass a guide wire. Nowadays, I think we do it on TEE, no need for fluoroscopy. TEE, we have got a good TEE specialist, anesthetist. So we do into the true lumen and then deploy the graft. Few of the Thoraflex grafts, you can see nice remodeling of the aorta. Most of them. And then is debranched or FET have got equal results. No, it is both of them. Unlike the FET, FET is the better because debranching and this putting this graft sometimes can produce endoleak, which could be type 1. We had one type 2 endoleak. And late complication of the problem is retrograde dissection into the ascending aorta. So we had these two, one case after three, about 6-7 cases we have done. And the right-hand side is the total arch done elsewhere. Patient came with retrograde dissection, renal failure on dialysis. About 3 of the patients with arch intervention I have reoperated. Because most of these cases, it would have been operated on the first time itself. That is one thing I want to make a point, that aortic arch aneurysms, one has to use their judgment and condition of the patient, everything put together before you do a very aggressive intervention. Unless a good surgery can be done, who is available, surgical treatment as of today is the best in aortic arch. Or cases where when they come with the previous dissection, where there's a landing zone is available in the graft, they are good. Otherwise, putting the graft in the arch, putting all these stents in the arch is sometimes very difficult to do, especially in younger patients and those with connective tissue disorders. Of course, you all know about this more than me. All these, so many things are coming, which is good. So if a good graft is available in a given patient who is fit, I think we must always do that. The thoracoabdominal aneurysm, I know it is one of the most difficult, and not looking forward to do an operation more than 1 or 2 cases a month. It's a very hard operation to do, but in younger patients with extensive dissection, it's a very good operation if you can do. Long-term results are excellent. This is a 24-year-old boy, and his sister, 26 male. I operated within a span of 1 year. Father was normal. There is no Marfan's in the family. The brother and sister I operated consecutive years. These are 20s, all young patients only. They do very well, because older patients only, when the morbidity is high, they can have problems post-operatively and intraoperatively, especially in dissections. This is a very interesting case we published about 15 years ago in Journal of Thoracic. Tuberculosis, you can see the multiple aneurysms in the aorta. You can see, you cannot, in the right-hand side picture, you cannot see which is the visceral artery, which is spinal artery, nothing is seen. So all those aorta is eaten up completely, and the right is the here only single kidney. That is a post-operative picture. Now coming to interventions, we have done, I think Murali has done more than about 12 total thoracoabdominal aorta interventions, and except one patient, all of them are doing well. And the longest surviving patient is about 12 years. I am quite impressed by the long-term results. We all get the graft ready-made order, and then not from the off fenestration we are not doing. Most of them we are doing with the pre-fabricated graft only. This patient is Marfan's, did a type A dissection in 2005 with a Bendal's operation, came with a distal dissection. This is the first successful elephant trunk procedure done in India. Frozen elephant trunk, I did it. We had a graft imported specially for him. Then he came with a descending aortic aneurysm, and this is a fenestrated graft used for the thoracoabdominal aorta. So in case he was not willing for surgery. I advised surgery because he was very young, but successfully done. This is also another interesting case. You can see the left coronary artery, huge aneurysm subclavian artery and descending thoracic aorta. We did in 3 stages actually. First we did the coronary bypass, replaced the ascending aortic aneurysm, then the thoracic aorta, then we did visceral debranching and endografting. This is a patient from Nigeria, came with aortic incompetence, mitral incompetence. We did multiple lesions in the aorta, mega aortic syndrome, did a root, arch, and classical elephant trunk. And then after about a week, we did the extension graft. The interesting thing, he had an abdominal aortic aneurysm right at the left renal artery, which was occluded. So the thing was what to do. Finally, I told our cardiologist to put a ASD device. He was scared to put it because he thought the aorta will be occluded. So we did an ASD device, and she is doing well. Aortic dissections, of course, I won't go more into that. Type A dissection, of course, surgery with the root replacement, and then after post-op CABG. And now endovascular root repair is coming in type A dissection. The first case has been reported. I'm sure it will have a good future with the technology developing in patients who are not fit for surgery. I mean, type A dissection is a disastrous thing to do even for surgery and also intervention. But as I said, every new invention will have a role. Initially, people may be saying no to that because all of you are becoming so good in these procedures and better software and hardware is available. It will be a practicality years to come. Then of course, complicated type B dissection, I won't go more because lack of time. So either it can be open surgery, total endovascular, or hybrid abdominal aortic repair. A hybrid also, I think, when the patient is not able to withstand a very major surgery, it's a good option, provided one can. I think the hybrid abdominal aorta, the most important thing is how well and how fast you can do the visceral anastomosis, especially the renal artery. Because if you take too much time in anastomosis the renal artery, patient will have renal problems. That will be the beginning of a complication. So it's important that isolate the vessel. Don't produce, mesenteric ischemia is not a problem. Renal artery you have to handle it, but if you are confident of doing that, it's a good operation. Of course, I will just pass on these slides. Now, to conclude, so I was fortunate enough in my career to see the rapid developments, which is, I can't believe, when I started my career of almost about more than almost 5 decades, and what is happening today. And then everything is available. So you have to choose what is right, according to the occasion, according to what suits you. And always you have a plan A and a plan B. What will happen if I cannot succeed this? I have a good enough standby. And like always say, an operation is posted for 8 a.m. on Tuesday. Operation starts on Monday morning at 8 a.m., not at 8 a.m. in the morning. Proper preparation, that is Abraham Lincoln's famous words. He will use 8 hours to cut a tree, 6 hours you have to sharpen your axe before you start cutting the tree. And expect the unexpected, and always surprises will be there. Embrace new technologies, which you all are the torch bearers in these new technologies. At one stage we thought everything for surgery. Now everything is, Rajesh was telling that everything is intervention in Scotland in my brief conversation with him. So after some time, surgeons will be, one problem which we will face is to who is going to tackle the complications. There are many people who are trained to do an open surgery. It is not most important thing. It's important, most important is what you can do it. You may be able to do so many things, but how well you can do it to the patient. For that you need a team, proper coordination, understanding, and proper decision making. On the previous day, like what I said, whether it is an operation, or an endovascular procedure, discuss with your nurses, your technicians and assistants, everybody, and be prepared for the worst. If you prepare for the worst, everything will go well. That's what my firm belief. If you go without any preparation, okay, I can do it. Even if I'm doing the 1,000th case of a bendel, I'll never take it lightly. As if you are doing the first operation, nothing will go wrong. Overconfidence will always create problem. Thank you very much once again for allowing me this much time to talk to you. I'm very privileged to be here amongst this august audience. Thank you.
Amazing whiz through what's happened with the aorta and the aortic arch over years. Maybe we'll take a couple of questions from the audience, if that's okay, sir. Anybody has a question for Dr. Bashi? There's a question over there.
Hybrid procedure earlier on I used to do spinal cord drainage. Nowadays, we don't do it. In our experience, it has not changed much. In fact, our anesthetists always say, the problem of spinal cord, if you put in a needle, sometimes bleeding, and the problems are more than, especially in endovascular procedures. Open surgery sometimes we will put, but by and large, we don't do spinal cord drainage. Important thing is to keep the blood pressure, the mean pressure above 100. It is very important. And since you asked that question, I must tell you also one thing. See, in the Western Hemisphere, especially in Europe and in the US, especially in Europe, they are worried about the length of the descending aortic graft. Initially, FET they made 15 centimeters. Now they are scared to put 15 and put only 10 centimeters because the paraplegia incidence is high. I have seen a lot of aortas there in Europe. I used to go to Italy and spend some time in the theater and all. Most of the patients, my own personal view is that most of the patients are older there. Atheromatous load is very high, and this atheromatous material will be going into the spinal cord and produce paraplegia. You have seen many cases of hybrid. We have done even up to 20 centimeters thoracic aorta. I mean, touch wood, we don't have, I've done about more 52 of FET procedures, not a single case at paraplegia. It used to be about 2 to 5% in most of the series. So I think one of the reasons is basically we are getting more younger patients, and atheromatous load also is less. We are getting more of dissections. I don't know about the experience of all others. This is what my personal feeling is that.
Yes, that's, we have stopped doing prophylactic spinal drains as well in our hospital, but we do spinal drains if the patient develops paraplegia as an emergency procedure.
Girish wants, what was the age of your patient, two patients?
One was around 60, one was around nearly
80. Yeah. I think older patients have more, that's what I feel. Because what I am telling is, if you look at the type of patients we are dealing with in aorta, most of them are about 15 years younger. As the age increases, definitely more of atheromatous disease will be there.
Last 2 minutes.
And the collaterals, and also our patients come late also. So naturally, some intercostals would have blocked, and then collaterals would have already developed. In fact, one of the surgeons in Germany, I met him, he is doing a study of embolization of the spinal arteries before thoracoabdominal aortic repair. It has not been published. I forgot his name. So he is doing serial embolization of the spinal arteries. Do it, and 2 months later you do it, and then wait for collaterals to develop. Whatever, I feel, if the spinal circulation is impaired, whatever may be the reason, either it is, in open surgery, whether you are not anastomosed the vessels properly, on an endovascular, all the intercostals are occluded. Spinal cord drain, where it helps, is very, very, even now many of the centers who are doing spinal cord drainage are not doing. Whereas thoracoabdominal open surgery people are still doing, especially in Texas, Dr. Koseli and all still says he does it. But I don't know. I mean, personally, I am not very keen to do that.
But there was a gap of nearly 3 years
Yeah.
for both the patients.
Very difficult to explain.
That there would be collateral.
Very difficult to explain. But one of the pioneers in aortic surgery who developed the first circulatory arrest, hypothermia, he used to tell, he is no more now, he used to tell, most important thing in spinal cord protection is keeping the mean blood pressure over 100. Keep the pressure high. If there was some reason, either it's a cardiac or extracardiac factors, patient develop hypotension, the chances of paraplegia is high. We have, Murali has done about 12 cases total endovascular. So we are lucky, I would say, we haven't had a single case of paraplegia. Number is very small to say anything, but we haven't had total coverage of the thoracic. I've shown you a few of the CTs. So
Thank you, sir.
Very difficult question to answer.
Time is up.
Thank you very much,
very
sir.
much.
Thank you very much. Thank you.
We go ahead further on. The next is Rohit. Rohit, everybody knows. Very aggressive aortic man in the interventional group. And he'll be talking to us on acute aortic syndrome and its management.
Good morning, everybody.
We will try and keep the time properly.
Yeah.
And so give us some a few minutes for discussion.
Discussion, yeah. So I've got 10 minutes.
For all the speakers, please.
Yeah. So we've got 10 minutes max, no? 10 minutes max. Okay. See, I'm going to talk about acute aortic syndromes, intramural hematoma, and penetrating atherosclerotic ulcer. See, the one thing, why this talk is important, I'll say you. There's a lot of inconsistency across guidelines. If you look at the STVS, if you look everywhere, because most of these studies are derived from a single center, and there are different definitions. There are different definitions for each what is IMH, what is penetrating ulcer. They're all are different if you look at across the guidelines. But I was quite lucky when I got this topic from Dr. Murli. There's an article which is a modified Delphi consensus that's come out in I think September 2025. It's still in press. I'll give you the link to read. It's a beautiful paper. There were about 83 experts that have come across various institutions across Europe, America, and Australia. You've got the cardiothoracic vascular surgeons, you've got the vascular surgeons, you've got the interventional radiologists, and a lot of people who have come together and brought up this consensus about IMH and PAU. Okay, so, and traditionally, at least what I used to remember is that they should be treated like an aortic dissection. Those were the traditional recommendation, but those are changing. So it's very important to have clarity. So first is, the aim of this talk of about 6 to 8 minutes is to clear your minds about some terms. I'm not going to talk about what's PAU, what's IMH. You have to know what each terms are importantly. What are complications? What are the characteristics of high-risk features? Frequency and timing of imaging, indications, technical aspects, all the stuff. Okay, now the first thing we have to do is, let's ensure standardization. That's part one, okay? So IMH is defined as intramural hemorrhage. So every time you look at a CT scan, you get, if there are 3 interventional radiologists looking at an aortic study with an IMH, you get 3 different conclusions. Just remember, without intimate there is IMH. Thickness of the hematoma is important. People differ. The thickness is intima to adventitious distance. Why that is important is because that defines what we do in patients. So the thickness of a hematoma is very important. So you have to know all this before we start talking about management. Then there's something called ulcer-like projections. They're actually small focal areas of contrast, within the hematoma. And there's a communication with the, it's called ulips, okay? There's a communication with the aortic limb. I'll show you a picture. And there's something which is similar called intramural blood pools. So these are the terms that you have to be using in your aortic report. The blood pools do not have a communication with the aortic ligament. They're usually connected to the intercostals or lumbars or bronchials. So if you look at the first picture with the red arrow, the one on the left, the red arrow shows that's an intramural pool. And on the top, you see the top red arrow, that's like there's a small connection like a stalk. So this is not a penetrating ulcer. This is an ulcer-like projection. Important. Anyway, so that's how intramural hematoma looks. I'll tell you why that picture is important later. PAU, very simple, broad base ulcer, atherosclerotic. It goes through the internal elastic lamina. It's quite deep. That is PAU. Okay, and in PAU, depth and width. These are the important things you have to know. The red arrow, so this is how you should measure the depth or width of the penetrating ulcer on a CT. The red arrow is the depth and the black arrow is the width. So is that also, that's all very clear. Now you know what's IMH, PAU, all that stuff, okay? So now, simple things first. Management starts with imaging. Everybody knows you do ECG, get a CT aortogram. For some people, you might do genetic testing. I'm talking about IMH and PAU specifically, not dissection, okay? Now, there are things that defines how a treatment is. One is complicated PAU IMH. The other one is uncomplicated, but with high-risk features. Now, it's very nice as this particular study, this particular consensus. Actually, couple of things are contrary to the ESVS guidelines that came up in September 2024. Now, complicated penetrating ulcers, imaging signs of rupture, refractory pain, refractory hypertension. Now, the thing in bracket I said, the presence of a pleural effusion, the PAU depth and width. If you remember the ESVS guidelines, the PAU depth more than 20 mm, or so the width more than 20, depth more than 10 mm was considered as complicated. It is not, okay? And total aortic diameter. These were rejected as a criteria to define complicated or high risk. So imaging signs of rupture, refractory pain, refractory hypertension. This is complicated. Now this uncomplicated should be considered high risk in the presence of the below 2 signs. I'll tell you the timing of when to do the CTAs. One is associated new hematoma, depth or the width of the penetrating ulcer increases, okay, and increase in total aortic diameter. So these are high-risk features, and these are actually, so what it says is that on just first imaging, you cannot say it's high risk, you have to do serial imaging. I'll tell you at what period intervals. And it's only then you can say it's high risk. So that was at PAU. Now, IMH, similar, complicated, is presence of rupture, refractory pain, refractory hypertension. Now, the presence of that, ulcer-like projections was rejected as a sign of complicated. It is seen, it's very common. Okay, just one presence of that. You have a intramural hematoma, you have got ulcer-like projection. That is not high risk. Okay, or that's not complicated. So uncomplicated, high risk patients are in the presence of any of the two below signs. That is, the hematoma thickness has increased. This is why I told you, you have to know it is the intima to the adventitious thickness. So that is increase in hematoma thickness. The onset of new ulcer-like projections. Initially you had 2, in the subsequent imaging you have got 4 or 5. So that's high risk, you need to think of treating it. And the ULP size increase, or it moves on to aortic density. So these are the things of high risk features, okay? So these are just to tell you what are the standardizations. Now it's about clinical management. So you have to treat, okay? So acute complicated PAH should be treated in the acute setting, we know that. Uncomplicated should be managed with conservative approach. Followed with CTAs. Now this is a question, it's 2, 7 and 14 days. This particular period didn't have a major consensus in that particular Delphi because some of them had a bit of a difference, but most of them agreed 2 days, 7 days and 14 days after onset is when you have to image. So you remember, so you're looking at evolution of stuff. That's when you think of it. So TIVA or OP is not indicated in this uncomplicated ones. Now, acute uncomplicated high risk, TIVA may be considered in selected cases. That we'll talk about later. Okay, so 2, 7 and 14 days are, so you know when to image if you're not treating it. Okay, now when to intervene for these high risk uncomplicated ones. That is sort of similar to what ESVS says after the acute phase, after 14 days. That's what, but there was no major consensus. But majority said after 14 days is better because sometimes the aorta is still healing. Okay, now we'll go to, I'm going to specifically talk about the TIVAR sort of bit. Now, operative management / TIVA planning. So it's very simple, 0 to 10% endograft oversizing should be applied, just like dissection, both to proximal and distal zones. These are the technical aspects. And what they have said is that an endograft without bare metal stent should be preferred. And I agree. Time is done?
Last 2 minutes.
Time is okay. So thoracic endo without bare metal should be preferred, okay? Now for the IMH, so proximal sealing of 20, so irrespective of what the companies say, I'm repeatedly telling you need minimum of 20 mm landing zone, free from hematoma. It's very important. Distal sealing zone, you can come up to celiac trunk, even there's a bit of hematoma, that's not a problem. But the proximal should be free of hematoma, more than 20 mm. I wouldn't go anything above zone 2 or proximal to zone 2. Same thing, no different, PAU, more than 20 mm should be as a sealing zone. Okay, what they say, it is always good to do, intra-arterial ultrasounds or intra-aortic ultrasounds. I used to conserve for landing zones, but I am not an expert in it, so I cannot talk much about it, but this is what they have said. Left subclavian artery should be preserved, no doubt. It could be extraendocrine bypass, branch endograft, or in situ finish. It doesn't matter. Even if it's an emergent one, you should preserve it. Okay, chimney graft techniques is not a viable option. It's absolutely not, and in fact, it is borderline stupidity to do chimney grafts in dissections in aortic, especially in the arch. Open repair, what I think is all proximal to zone 2 with the current devices following the same principle, all proximal to zone 2 should be an open repair. Because none of these grafts yet are designed to treat upstream aorta, that's what I think. Follow-up should be performed 3 to 7 days post-procedure. Okay, so I'm just going to go for clarity. I just have to rush a bit. So definitions should be clear. First thing, you decide between complicated and uncomplicated. You should know the characterization of uncomplicated but high risk. Imaging at 2, 7, 14 days if you're not treating it. Non-bare TOR is better with 20 mm landing. LSA should be preserved. timing for high risk, no, about 2 weeks later you can do, and post-op CT within 3 to 7 days. This is sort of a bit of a definition. So this is the international expert consensus. This is the article. Okay. So I mean, the final take-home message is that this is an interdisciplinary approach. We might be the best fenestrator, we might be the best endovascular guy, but it doesn't mean what you are good at. You should be doing what is best for the patient as a teamwork. Thank you. Nandi Namaskaram.
Thank you, Rohit. Really completed the whole discussion on the subject. Really congratulate you for that. We'll take one comment or question if there is on the subject here. I'm sure a topic which is often difficult to handle, taking a decision on that. Rajesh, you have something to comment?
Yeah, I completely agree with Rohit that try not to use a chimney technique when you're treating IMHs. The main danger is conversion of a type B IMH into type A, and then you have to call Dr. Bashi very quickly to do an open repair of that patient. So that's why we avoid.
Great.
Dr. Murray.
Yeah.
You got the, what I mean was the no. Yeah, but now you've got the, Tirumu has got a non-bimetal stent, in the sense with the non-bimetal stent, and also Percutech has got releases. They've got this NBS.
Both the Gore and Cook grafts are.
Gore has got now, yeah. I think LifeTech is coming with, I don't know if the LifeTech guys are here. Satya, you got a non-bimetal NBS stent, or you're coming up with it?
Great. So thank you again, Rohit. A great discussion and a lot of learning here. Dr. Deshmukh, can you take over?
Thank you, Rohit. Still dwelling on the topic of aortic surgery, which Dr. Bashi had already explained. When Bashi was trying to do aortic surgery surgically, we were trying to learn what is, how does the patient present. That was third MBBS, Love and Belief, anybody remembers. And that's aortic aneurysm of signs, aneurysm of symptoms, and aneurysm of latency. I still remember those words. Let us proceed further to type B dissection, and Dr. Santosh will let us know what are the present guidelines and when to intervene in type B dissections.
Good morning, one and all. Welcome to the session. And we'll see when to intervene with the latest guidelines on type B aortic dissection. So classically, type B aortic dissection is divided as complicated and uncomplicated. Complicated is one where we have rupture or malperfusion, which is either dynamic or static, or the patient has a refractory pain or hypertension which is not controlled with medication. So in this patient group, we have clearly known that TIVAR outperforms surgery because of the very high in-hospital mortality with operative repair in complicated type B dissection. Whereas in uncomplicated, we don't have any of these features. We have no rupture or malperfusion, or pain is controlled with medications, and the BP is less than 120, SBP is less than 120 with medications, and these patients traditionally have been managed medically. So in the complicated group, there is definitely a lower incidence of in-hospital mortality, paraplegia, respiratory and renal failures with TIVAR. But there is a little higher rate of re-intervention with TIVAR because of adverse remodeling in the delayed stage, where that is the only area where the surgical repair scores. But still, for the past 2 decades, TIVAR outscores surgery in type B aortic dissection. There is still some morbidity with TIVAR in this group, in the complicated group. It's a small rate of stroke, which is around 2 to 3%, a spinal cord ischemia rate of 5%, access site complications as always, and we have a small risk of retrograde type A dissection. This is, although this is small, this is very significant because 1/3 of these patients die. And in the delayed phase, we have a stent graft induced new entry tear, which is distal to the stent graft, also has a high mortality, and there are some other complications like a persistent re-entry tear, which is filling the false lumen, and also a type 2 endoleak, which is seen in quite a good number of patients. So this is the problems with TIVAR that we have in the long term. In the uncomplicated group, so why was the decision to not intervene formulated as a guideline? So there were 2 major trials. The observational registry IRAD, which came out in 2000, examined all dissections, type A and type B, and found that in type A definitely surgery has to be done because the mortality of wait and watch is very high. Whereas in type B, the 30-day mortality with surgery was higher, so surgery was not favored and medical therapy was favored. Of course, TVAR was not examined in the IRAD registry. The first randomized trial for the TVAR in type B dissection was the INSTEAD trial, which included uncomplicated TVARs, because we knew that complicated TVARs have to go for TBATs were good to have to go for TVAR. The uncomplicated TBAT, 140 patients were examined, randomized to 2 groups with medical and TVAR, and found that there was no significant difference between doing a TVAR and just managing medically in these uncomplicated patients at the end of 2 years. There was no survival benefit. So this is the reason why the guidelines said that there is no need for TVAR in the uncomplicated group. But is it really uncomplicated? Because this group of patients which form the majority of type B dissections have an early mortality of 3 to 10%. And 40% of these patients will require a late intervention because of adverse remodeling, and the long-term survival is not great. It's around 50 to 60%. So all these patients do not have a very good long-term outcome with medical therapy. So then came the extension of the INSTEAD trial, which was published in 2013, which showed a clear survival advantage at 5 years, which was not present at 2 years. So definitely, because of the adverse remodeling of the aorta, which happens with just medical therapy, the mortality kept going up in medical arm. So the TVAR arm performed far better in the 5-year time period. And around the same time, the ABSORB trial was published, which again measured the radiographic remodeling criteria and found that the favorable remodeling was present in a majority of patients with TVAR. So what were the high-risk features in this uncompleted group? So the total aortic diameter of more than 40, false lumen diameter of more than 22, an entry tear diameter of more than 10 with an inner curve location, which is opposite to the classic outer curve location, or a partial false lumen thrombosis, which increases the false lumen pressure. All these were considered high-risk features in the uncomplicated group, and all the latest guidelines show a class 2 recommendation for doing TVAR in this group. So when do we do it? In the acute phase, we know that the aorta is very fragile, the intima is like a wet tissue paper, so it's not the right time. In the chronic phase, whereas it becomes like a leather and it's very thick, and remodeling is definitely not possible in a chronic time period of more than 90 days, whereas the right time to do the procedure in uncomplicated TBAT is in the subacute period between 2 weeks and 3 months, where the inflammation has settled but the intima is still pliable for the remodeling. A chronic type B dissection is altogether a different scenario, because complications are higher with TVAR and the intima is like a leather. So we have different criteria: an aneurysmal degeneration of more than 55 mm, a rapid growth, or the patient becomes newly symptomatic with rupture or malformation. These are the indications in chronic. Of course, there are different techniques in acute and chronic. I'm not going to the details, but definitely we have to be conservative of the oversizing side in the acute period, whereas we have to be quite aggressive, because what we are doing in the chronic phase is basically we are excluding the aneurysmal component of the aorta. So we have to cover all the entry tears. We have to be covering the entry as well as the re-entry tear, which is distal. Whereas in the acute phase for an acute TBAD, or when you do a subacute phase for an uncomplicated TBAD, we have to just be worried about the entry tear, and we have to be very conservative on the oversizing. What about left subclavian artery? We have seen in the previous section that we have to, as much as possible, revascularize that. But the guidelines say that zone 2 landing or the covering of the left subclavian artery may be required in 40% of urgent TVARs, but it has to be revascularized in certain conditions, where there is a dominant left vertebral artery, there is a persistent lima, or there is a dialysis access on that arm, or a functionally absent right vertebral artery. These are the cases in emergency also. We have to definitely do a revascularization of the LSA with either surgery or an endograft. Whereas all the elective cases have to undergo left subclavian artery revascularization. This is the current guidelines by all these societies. So finally, to summarize, this is the whole summary that you have to take home. In any acute type B dissection, we have to first classify as complicated or uncomplicated. In classic complicated with rupture, malperfusion, or refractory pain or hypertension, patient has to go for an urgent TVAR. That has to be done in the emergency. There is no other go. We have to take the risk for type A, retrograde type A dissection, we have to conservatively undersize and seal the entry tear. Whereas if it is not complicated, then go and see at the radiographic features if there are high grade, high risk features. If the total diameter is more than 40, false lumen more than 22, entry tear more than 10, on the inner curve with a partial false lumen thrombosis, these are the patients who have to undergo a subacute TEVAR in the period of 2 weeks to 3 months. If not, all the other group of truly uncomplicated type B dissections have to go for best medical therapy and surveillance with a CT at 1, 6 and 12 months and then yearly CT to see the remodeling. And if there is any adverse remodeling with aneurysmal degeneration, then these patients have to be considered for a chronic TB, type B dissection treatment, but of course there is a lot of risk involved in the chronic type B dissection treatment. Thank you.
Great talk. Thank you very much.
Thank you, sir.
Thank you, Dr. Santosh. Very well explained management of type B dissection, including
Last
guidelines.
2 minutes.
One point to just mention, even in cases of chronic dissection, year-old, sometimes patients come with malperfusion. And I have done cases where augmentation of the true lumen by putting a stent graft during TEVAR, it augments the true lumen, and the symptoms completely resolve. So this might be might be fibrotic, the flap, but still there is good response even in chronic cases.
So the technique has to be slightly different. So we have to tailor it to the chronic, the leather type of intima, because we have to little bit oversize compared to the acute situation. And then we have to cover the distal re-entry tears, which we have to, the coverage length has to be as much as possible. That is the only difference.
Use the uncovered stents also, with the covered and uncovered,
Sir, in the acute situation we have rarely used.
Yeah.
In the
No, but in the
situation,
chronic one which
chronic
he's talking
situation,
about.
yeah, chronic situation, definitely there is a role for an uncovered stent in the abdominal aorta, definitely, sir. So if the covered portion reaches up to the celiac, and then if you can place an uncovered stent like a petticoat in the abdominal aorta, definitely the radial force on the flap increases.
What about you, Rajesh? How is it in these patients?
We try and avoid the petticoat stent if we can, but in spite of covering the entry tear, then if you still have malperfusion issues, you can try the petticoat stent. Sometimes you have to stent the individual visceral vessels to get, if you try and do it if there's malperfusion issues, in my experience.
Great. Thank you again.
Time is up.
I think we go ahead further.
Any other question? Okay, thank you. So, our next speaker is Dr. Girish Varatkar, sir. Dr. Girish, sir, is a well-known expert and has vast experience in endovascular management of aortic diseases. It is our pleasure to have sir again to speak on juxtarenal and thoracoabdominal aneurysms, endovascular management with custom-made and surgeon-modified devices. Sir, please.
Thank you. Respected senior colleagues, Dr. Bashi, one of the pioneers of aortic surgery in India. And most important is I'm going to talk on this topic, but it's like if you have a hammer, everything looks like a nail. It is not that way. It also is important that if the patient is young, surgery is the first choice. Unfortunately, in my side of the country, there aren't too many surgeons doing thoracoabdominal aneurysms or dissections. So we are quite often compelled to do it. Those who can go to Chennai, they go there. However, if the patient lands up with a thoracoabdominal or a juxta-renal aneurysm, then these need to be treated, especially if the patient is old, unfit for surgery. So it is the main important thing about it is that thoracoabdominal and juxta-renal aneurysms are very, very difficult to treat. Why? Because there are diverse branches, vessel anatomy. CMD is the preferred option, though it's a slightly more expensive option, but it has many an advantage. Why? Because the CMD is made using a 3D template using the patient's CT scan. They combine the 3D template with computerized planning software so that they are very accurate in the positioning of the fenestrations or branched grafts that may be required. So which are the companies making them? There are Cook Medical, there is Life Tech, there is Teremo, and there is Jotech as of now. Now, I'm going to basically be talking about only thoraco-abdominal because there are newer devices coming for the arch, which I think the next speaker will talk on. So what are the types of CMDs we have? They are fenestrated grafts. They are fenestrated grafts with scallop. We have branch grafts, that means they are internal branches and external branch grafts. You have fenestrated as well as branch grafts, and you also have now the off-the-shelf graft devices available. Now giving you an example, like in this case, if you see there is external branch grafts, there are fenestrations, and there are also internal branch grafts. So that means to say, if the branches are projecting outside, they're called external branch grafts. If they are projecting inside, then it's called an internal branch graft. So the perspective is that majority of the demands of EVAR have been met with chimneys, fenestrations, branch grafts, CMDs, resulting in us pushing the limit to treat difficult pathologies with good outcomes. The arch still poses a challenge due to the diverse anatomy and anatomical variations for TVAR, and hence the thrust to address these challenges has arisen. What is the bigger picture in this? Innovation, like Dr. Allen of STS made in the presidential address, doing something different that matters. Why is minimally invasive arch surgery important? Are there many cases? Are there being innovative just because we can, or does it really matter? That is the important point that one must think of. So in conclusion, the next generation is transforming the management of EVAR and TVAR to solve the unmet clinical needs. More flexible and low profile devices with lower profile and available are in development still today. New devices may eliminate endo leaks by aneurysmal sealing. Branched and fenestrated grafts may enable EVAR in juxta and suprarenal AAAs. Branches and fenestrations grafts may widen the horizon of endovascular treatment of the arch pathologies, and efficacy and safety of newer devices need to be evaluated in larger clinical trials. So what are the advantages vis-a-vis, say, CMD versus a physician-modified graft? More precise positioning of the fenestrations in the CMD, multiple diameter reducing ties available in the CMDs. That means to say you don't open up the device completely, you have space between the device and the branches so that you can cannulate them better. If one fenestration is positioned, automatically you can be really confident that all the other fenestrations will align. Ability to partially deploy and repositioning, that is the advantage again of CMD. Availability to have branches and fenestrations, whichever is your choice, that you can decide depending on the anatomy. Availability to have differential diameter grafts across the entire segment. Suppose you can make a custom-made device, larger diameter above and lower diameter below. Multiple pre-cannulations is possible with the CMD. Usually brachial artery cannulation is not required. Everything can be done femorally. Usually large sheaths are positioned in the opposite groin so that you can take multiple sheaths across. Less stress for the operator, less time consuming, and most important, less radiation to the patient and the operator. So limitations, yes, the CMD takes 2 to 3 months at least currently in our country to ship. Emergency cases have to be treated with a physician-modified graft. Cost slightly higher than the physician-modified graft. It would be, I would think, anywhere varying from 3 to 5 lakhs difference. The way ahead would be 40 to 50% of the cases we are modifying the device because you don't have the time to wait for 2 to 3 months or for cost limitations. With refinement of the off-the-shelf devices, the dependency for custom-made devices is expected to come down by 10 to 15%. The next major shift to the off-the-shelf devices is happening in the arch, as we have seen with the LifeTech device. Now, just showing you a couple of cases. This is a 43-year-old male, ex-railway employee, presented with a pain abdomen, admitted in an outside hospital. Blood pressure was 130/90, heart rate was 84. Hemoglobin, we don't have the records of that hospital. CT done outside showed a AAA in August 2022. On admission, the hospital hemoglobin was recorded as 7.5. 2 units of packed cells was given. Patient stable on admission, later developed hypotension, blood pressure of 70/30, 2 more units of packed cells given, clearance obtained from the railways to proceed with the procedure, and procedure planned on an emergency basis. Unfortunately, I didn't have the CD, but I had the films, and you can clearly see that this is now a ruptured abdominal aortic aneurysm. So I won't go into the details now. In an emergency situation, the risk of open surgery is much higher than endovascular. So we took the patient up for endovascular. The protocol we manage is the candidate is an emergency, for emergent surgery, you do a CT scan, non-suitable for EVAR or is suitable for EVAR. And then if it is suitable for EVAR, you would proceed with the EVAR procedure. So what the plan was, left renal artery was occluded, space between the celiac and SMA was present so that we could land the device below the celiac. Bifurcation was not involved, single tubular graft was taken, deployed just distal to the celiac trunk, physician-modified graft, 2-vessel fenestration to the SMA and right renal. So this is the angio. I have not shown you the device that we prepared, but we did the 2-vessel fenestration for this case. Positioned the graft, cannulated both the fenestrations. Sorry, my hand came into the image. Cannulated the SMA, cannulated the renal, and stent graft, B graft 8/37 placed in the SMA and deployed. Right renal was stented with a B graft 6/38. Post-renal stenting, angiogram done. There seemed to be a slight endo leak, so we decided to balloon it. Always use the coda balloon and simultaneously inflate the branches. Thereafter, we ballooned the renal. Patient stabilized overnight, extubated next morning, hemoglobin stabilized, shifted to the ward the following day, discharged 3 days later was lost to follow-up. Came to the railway hospital again 1 year later, pain abdomen, occasional postprandial pain, hemoglobin dropped, CT angiogram done, and CT angiogram showed that there was an occlusion of the SMA stent. And luckily we had not covered the celiac. You'll know why I said luckily, because later on we had an issue to try and recanalize the SMA, and we also had an endo leak which we suspected was coming from the renal. So we went into the renal. You can see that there is an endo leak, and then we reinforced that fenestration with another covered B graft, and thereafter we have the leak stopped from the right renal. However, we could not manage to cannulate the SMA. We tried everything, we could not. We saw the IMA, we went through the IMA and tried to retrogradely pass a micro catheter. See, this is from the aortic side, and you can see my micro catheter going all the way. You can see in the right picture, the microcatheter is going, but still the wire is not crossing that occlusion. So I presume there must have been a sharp kink in this graft. But he just had slight postprandial pain. We left him as it was. We closed the endo leak, and thereafter the patient settled. His postprandial pain went. So he is now on the IMA and the celiac. So this is how a fenestrator looks like. Your left picture will show you that we've just made a fenestration. Then the fenestrations we line with a coronary wire so that you can visualize and suture it with 6-0-proline. And that's the suturing of the fenestration you can see. So that was a physician modified graft. Now I'll show you a custom made device. 61-year-old female, pain abdomen, USG juxtarenal aneurysm, investigated with CT angio, showed a juxtarenal AAA. Now you can see here, I'm just showing you the picture because we don't have that much time to run the CD. So we decided to do a custom made graft for this patient. So the custom-made device was fenestration, 4-vessel fenestration for the celiac, superior mesenteric, and both renals, and then a bifurcated device below. So that was the bifurcated device, and we had planned to do the bifurcated graft from the left side. So the plan was a scallop for the celiac, 3-vessel fenestration SMA, both renals, coil the left internal iliac, and do an IBD, that's an iliac branch device for the right iliac. So you can see here now, we have coiled the left internal iliac, and thereafter we started the procedure. This is the scallop for the celiac trunk, and then the 3-vessel fenestration. We positioned the graft and then partially deployed it. We cannulated the SMA and both renals. The right renal was a difficult cannulation, but finally we managed that. So retaining sutures were released. You can see the graft on the left side, the graft is opening up once we release the diameter reducing ties. The top cap was deployed. Left renal stent deployed, Bentley 622. SMA stent deployed, which was a Bentley 827. Right renal stent deployed, Bentley 628, and finally we took the bifurcated graft, and unfortunately what was happening was the graft was opening up on the same side. The contralateral limb was opening on the same side. So we managed to deflect it to the opposite side and deployed it. Deployed the ipsilateral limb, and now is the problem. Any comments? Anybody noticed anything there? Okay, I'll show you what the problem was. Now when I came to retrieve the device would not come out. It was stuck. Every time I tried to pull, the graft would come down. So now the fenestrated component was otherwise in good shape. So we did a check angio, and you can see that there is no flow in the graft, in the ipsilateral limb. And we injected from below, again contrast is not going up. So obviously there is a problem at that junction. So the dilemma was what? Pull the device further down, which failed. Push the device further up, failed. Open surgery was an option. Snare the device via axially and try and retrieve it. Any other option we were just contemplating. But what has happened? Basically, what has happened is we decided first, most important is retrieve it. So we cut off the hub of the delivery system. We withdrew the proximal. I think it's a 20-minute talk.
Last
right?
2 minutes.
I think it's a 20-minute talk. We withdrew the delivery system. So we had the central stellate of the delivery system. We advanced a 7 French guiding catheter over that stellate, forced the guide wire through. Once we forced the guide wire through, we advanced a Terumo wire within that, while we were withdrawing the guiding catheter. Finally, we placed a balloon across that segment and then balloon dilated it. Now you can see what happens. Can you see we are inflating the balloon, and you see the entire device twisted. So obviously there was a kink in the device, that's why the delivery system wasn't coming out. And why did that twist occur? Because we were twisting the device when we were deploying the contralateral limb so that we could have the contralateral limb on the side that it should be. Anyway, once we ballooned it, poor flow still across that lesion. Then we redilated the segment, slightly higher pressure, and we managed to get a better flow. And thereafter, we put a reinforced Bentley balloon mounted stent there, and thereafter it was straightforward. So this was the finish line. Then finally we went into the contralateral internal iliac artery, because we had to put an IBD. We placed the IBD, cannulated the IBD, and put a covered stent in the iliac branch device, and then finished the procedure. So this was the final picture. No endo leaks, good flow in both iliac arteries.
Time is up.
And so what caused the problem? If you see in the left picture, okay, I think it was a 20-minute talk, not a 10-minute talk. Okay, it's 20 minutes are up. Okay, this is the last slide. Anyway, so let us, there was just data that I was going to give. We've done quite a few fenestrations, about 136 patients, and also done about 158 CMDs up to now. Thank you.
Girish, great experience that you have with all these CMDs and on-table fenestrations. Definitely this is one area where you got to be ready to handle difficult situations. So be prepared with that, and I think the young blood should do that. The older one should probably start settling down easy, because these procedures may take a lot of time, lot of contrast, lot of radiation, so one got to be careful with that, and there's a whole lot of learning with this. And what is the most difficult one that you've had, or taken longest time that you've ever had with these many?
See, that was, usually the CMD does not take very long. Because we are so confident that once you align one fenestration, all of them fall in place. The problem is physician modified grafts. However good you may be, that 3D projection that you have on your software, which you don't have in your mind, that is when the problem arises. The longest I have taken is about 12 hours. That is basically because one of the fenestrations do not align properly, or like we had recently, though it was a CMD, the anatomy was so bad that there was a thrombus there, and from that thrombus there was this renal coming out. And there was a lot of space between the graft, which was CMD, and the renal. I think Rohit was, yeah, we struggled for how long for that? Just, something like that. So it was just that the anatomy is what? Otherwise, most of the time in CMD, there is no issue at all.
When you have long times with like that patient that you mentioned, do you do anything to reperfuse the limbs in the meanwhile? Because the big problem is the long ischemia times, because your sheath is occluding the limb flow.
No, what happens is normally once we, as far as the CMD is concerned, the most important is the fenestrated component. Then you have the pajama. So what we do is, in case it's going to take so much time, anyway you've deployed it now. So we have no option. So then we deploy the entire graft and remove the delivery system, so the perfusion still remains. But yes, if you are doing a physician modified graft, yes, that is an issue. So what we do is that we try and in between release the tourniquets, let some blood flow, and then retie the tourniquet.
So yeah, definitely a therapy which needs a lot of learning, and I would encourage youngsters to take it up, put in their heart and mind into it, and do these procedures. Really challenging and very rewarding also at the same time. Thank you very much, Girish, for a lovely presentation.
Thank you.
We have Kamal Pathak, another expert in aneurysm management, and he's going to talk to us about current trends in endovascular management of arch aneurysm. Most challenging part. Thank you. Thank you, Kamal.
When he told me about this topic, I told him, I think you're trying to bully me to speak on, so I'll be speaking on arch aneurysms, current trends in endovascular management. The current trends in endovascular management of arch aneurysms is to improve the endovascular techniques and to decrease the complications which are associated with surgery. Surgery has been the gold standard for aortic arch aneurysm treatment. But in spite of the improved cannulation techniques, improved cerebral perfusion, and the surgical techniques, the mortality and neurological impairment have been very high, as well as, say, renal impairment and cannulation site injuries. Hence, endovascular repair is more encouraged because of its minimally invasive, doesn't require hypothermic circulatory arrest, and there's no rerouting of the aortic blood. The key trends in endovascular management is to shift from open surgery to hybrid to totally endovascular means. The shift towards total endovascular repair is going towards connecting all the supraaortic branches by just endovascular means. The branched and fenestrated stent grafts help in looking after the supraaortic perfusion. Hybrid procedures and physician-modified devices are the most common procedures. Custom-made devices are expensive and also have a time lag before they are available to you. Now, the hybrid procedures combines open and endovascular means. In the open, they will do a bypass surgery or a debranching, and then post that you can put a stent graft into. The frozen elephant trunk was introduced by Koch, in which the ascending aorta and the descending aorta were dissected. You put a wire from the femoral artery and took it out in the operative field and put a TIVAR device retrogradely. And then you could suture the Dacron graft into the native aorta or aortic graft, and the arch vessels were attached to the proximal Dacron graft. This was how it was, and the people who have done this can remember. You can see my second last lower slide, in which we used to put a yellow tape outside the graft because we didn't know till where you had to push the graft in before you started deploying. And then, of course, the surgeon would connect the vascular stent graft to the Dacron graft. Now the Evita Open Plus is the one which was available for a one-time procedure to treat the ascending aorta, the arch, and the descending aorta. This is a one-piece device, has a cuff in between which you suture to the aorta. The the proximal part has a stent graft which you put in the descending thoracic aorta, and the upper part is the vascular graft in which an island is made and the supraortic branches are attached to it. This is how it looks. The descending aorta is opened, the stent graft is deployed, the cuff is sutured to the aorta, and then the vascular segment of the graft is attached to the ascending aorta, and an island is made, and the supraortic branches are attached. Evita Open Neo was the next generation of the same device. This had, this was more patient specific. It could be deployed for zone 0 to zone 3, and it had a 10 mm side branch for perfusion. It facilitated more proper suturing of the supraortic branches. The straight branch, you could do the island technique. The trifurcated branch was used for the zone 0 deployment, and the branch device was used for zone 2 and 3 deployment. The Thoraflex hybrid graft is a similar graft which has again 4 branches and can be used in a similar way with the cuff to suture to the aorta. At our hospital, we are doing deep branching the most commonly. In deep branching, you debranch the supraortic branches and you attach it to a vascular graft. The vascular graft is attached to the ascending aorta, and then you deploy the stent graft. We are generally doing the Y graft. We are putting the graft from the ascending aorta to the innominate artery and the left common carotid artery, and we are doing a carotid left subclavian bypass. Here's an example of an aneurysm of the ascending aorta. That's the surgery where he has put a Y graft on the slide on the right. You can see the Y graft which has been put to the innominate and the left common carotid artery. And if you notice, he has put clips just above where he has put the graft. That clip actually helps us to deploy our stent graft once we are inside, because so that we do not cover his Y graft. This is the angiogram you do first before you put the stent graft. It shows a good functioning Y graft into the innominate and the left common carotid artery. And this is the carotid subclavian bypass. The clip had been put by the surgeon just in the subclavian artery, but he could not mobilize this aneurysm. Hence, he could not put the clip proximal to the vertebral artery. And if you notice, there is a retrograde flow of the vertebral artery into the subclavian artery. Hence, we had to go through the aneurysm into the subclavian artery and put a vascular plug there and then deploy the device. And post-procedure aortogram shows you well-functioning Y graft, and there is no retrograde flow from the left vertebral artery. And this is the CT, which shows you the grafts are working and the aneurysm is not seen. Nowadays, you have branch devices. The Gore thoracic branch device and the Endospan Nexus graft are single branch devices, whereas the Tenimo Relay and the Cook Zenith, they are the multi-branch devices. This is the Gore Tag thoracic endograft device. It's a single branch device. It's used for type 3, type 2 deployment. You have 2 wires in it. You can put one wire in the ascending aorta and the other in the left subclavian artery. The aortic wire is pushed through the center of the graft, whereas the one for the subclavian can be taken through a temporary side branch, and then you deploy the main device, and then you go through the already indwelling wire and put a stent in the subclavian. the instructions for use tell you the diameters which are required. In the endospan nexus device, you have to have a supraortic debranching. There's two branch devices. That's the one is the ascending aorta, and the other is of the arch and the descending aorta and the innominate. You deploy through a through and through wire from the innominate to the arch and the descending, and then you deploy the ascending aortic graft, which is then locked onto the arch graft. The newer Duo has a branch for the left subclavian artery too. The Terimo relay branch, this has a two branch grafts for the innominate and the left common carotid artery. It will require a carotid to subclavian bypass to go for the subclavian artery, and you deploy the main device from the femoral artery, and the branches are cannulated from the retrogradely from the carotid and the in the innominate arteries. The total endovascular repair is looking at doing the whole thing endovascularly. This is the Zenith Cook Zenith branch device, which has which as you are deploying looks after the supraortic branch flow. It has got two inner devices for the innominate and the left common carotid artery, and has when I come to LifeTech, this is the concave supraortic branch device, a similar branch device.
Last 2 minutes.
It shows it has a window through which the supraortic flow is maintained, and you have those two branches for the innominate and the common carotid, and one for the left subclavian. This is how it looks once it's full, and this is an example of the device placed in an aortic aneurysm. The Hector device also is a similar device. Of course, off-label treatments are parallel grafts, in situ. I'll go fast through these. This is the chimney grafts. In situ fenestrations can be done through laser or through the wire. And then, of course, fenestrated grafts, which Dr. Giri showed so nicely. And this is an example of a fenestrated graft. You can see you deploy the graft partially, cannulate the fenestration, and once you have cannulated, deploy it fully, then you put your stent graft there, and that's the post-procedure showing that it's functioning well. The future is that is thought that the Bental procedure will be replaced by an endobental. This consists of a device which has a TAVI device attached along with the tower device, and has got fenestrations on both sides for the coronary arteries. Thank you.
Kamal, that was excellent on what the surgeon can do and what the interventional radiologist can do. Looking at such prolific pictures, Dr. Bashi, do you think that the younger generation of surgeons feel threatened by all this total endovascular treatment of aortic aneurysms?
Thank you. Great
Time
talk.
is up.
Great talk. I don't think the surgeons will feel threatened in the near future, because aortic arch comes in different ways. The aneurysms, none of them are the same. Two aneurysms are different. And to do all these things properly without any complications, it's very challenging. If you look at the learning curve is so much in interventions also. If you look all over the country, only very few people are able to do a total endovascular aortic arch. And I have had the opportunity to treat a few cases who had complications after that. That's number one. Number two is the open surgical mortality. The statistics, this first slide he showed is pretty old slide. In my personal experience, at the moment, the aortic arch surgery, I have done more than about 300 aortic arch. The last 10 years, the mortality is around 4%. And I had only the incidence of about 3 neurological complications, because we have better methods of cerebral protection plus cerebral antegrade perfusion, and taking precautions to make sure the techniques, you do it in a shorter time. As the experience becomes more, the results also definitely will be much better. and newer and newer things are available. I'm sure in the more and more better graphs available, sure enough there will be equal number of cases for the interventionists and the surgeons. Always, as I said, it will be like husband and wife only. One who is bigger, it's difficult to say.
Wife always.
I think in the end, probably good discussion and a good teamwork between the surgeon and an interventionist would play a good role. And I think, as Dr. Bashi said, and the gray hair here, both of us would agree that surgery will still remain, and we would complement each other rather than compete with each other. Yeah, Rohit. Rohit, there's a mic here. Can you have a mic, floating mic or mic
Thank
for
you.
the audience?
So I want to ask about this, as the newer graphs come and we are coming closer to the annulus and to zone 0, I'm still not convinced these graphs are fit enough to fit in the ascending aorta, because the ascending aorta hemodynamics, the myomega is completely different. Even if we look at the wall shear stress in the ascending aorta, it'll be interesting to see in the long term how these graphs will function. Because we have just started with this newer graphs, and I'm in 8 to 10 years, when you look at it, the wall shear stress, the peak systolic velocity, the coronary, I think all that will be affected when you do an endovascular repair in zone 0. So which is why I still feel that
yeah, I agree with you, because you really don't know how it's going to be, and also the device sizes also, say how they are going to come up with the Indian population, the sizes that we have, are they going to match them? So it's again a real beginning, restart. So I also have no answer to what you're asking.
Surgery is going to remain, and I think the most important thing is to make sure there are younger surgeons trained to do open surgery as well, isn't it, Dr. Bashi?
Of course, I think. And another thing also is, when there is a lot of scope for arch intervention, especially when patients come with previous ascending aortic replacement, because the most important thing is landing the endograft in an area where it's not a native aorta. So that those cases who are sick patients for open surgery, because one thing is happening is our average age of Indian population is advancing. We will get, and in a population of 1.4 billion, we will have plenty of cases in the next 10 years. That's what 20 years ago I used to tell all my younger surgeons, aortic surgery, if you take now, you will not have time to operate on the aorta. Please concentrate, because it is being seen now. A large number of cases, if you take the total number of aortic interventions and surgery done in our country, is unbelievable. So I'm sure the future is definitely open for the youngsters who are, even though it is challenging, once one get addicted to the aorta, that's what I feel. I'm sure women will agree with me.
Thank you, sir.
So one major problem we face, because in the teaching in cardiothoracic surgery, when you have ascending aorta aneurysm or dissection, what they say is the bare minimum you do and come out. Then the bare minimum is just replacing the ascending aorta and come out. But that is a problem for us later on when we have to do some intervention, which most of the time we have to do. Why not change that whole paradigm and say that yes, bare minimum, but at least do a debranching? Isn't that a feasible option?
I didn't say that because it's not a surgical audience. Yeah. See, today in type A dissection, one thing about a scenario in type A dissection is usually it comes in, especially all over the world if you take, it comes in odd hours of the time. And the surgeons who are doing it, whoever is on call will do. In the US also there is a statistic, if a surgeon is doing 10 or 15 aortic dissections a year, the mortality will be around 5%. Fellows doing 2 or 3 cases, mortality is about 25 to 30%. So in an ideal situation today in type A dissection, at least in most of the centers who are doing active aortic surgery, we do the proximal aortic arch always. Always do the proximal aortic arch, so that you don't have to open the chest again. Number one. Number two is, if there is associated aortic valve disease, either you replace the aortic root or repair the aortic valve, so that further interventions will be easy. So in our unit, we don't open the chest again after aortic dissection. Something happens, you can deal with just a carotid subclavian bypass. most of the centers, but the thing I always tell is if you are not experienced in doing an aortic arch, it's also a challenging thing, circulatory arrest and all those things. And then you do the ascending aorta and come out. A live dog is better than a dead lion. Send the patient out of the theater. If a complication happens later, distal aorta enlarges, some senior fellow will be able to do it electively with better results. Number three, in an acute situation, sometimes the dissection goes to the arch vessels. That time debranching will be a little difficult. You have to do a circulatory arrest and do direct suturing, because when you do debranching, you have to put a side biting clamp on the arch vessel. That is one technical thing, especially in an inexperienced person. So we get lot of cases because most of the centers they do. There are some surgeons who suture the dissection, and I have done a couple of cases where first operation they didn't even replace the ascending aorta, but patient lived for 3 years. So it depends upon the patient, where he goes and who is doing the procedure. So I feel that more and more surgeons are getting trained now, we will get a better surgical results and more aggressive approach for type A dissection. And so you will have easy way of landing the graft.
Thank you, both of you. I think we go ahead further. Yeah, Anil?
Thank you, Kamal sir, for wonderful presentation of the management of aortic arch aneurysms. Let us move to next session, next talk. That is our next speaker is Dr. Renay or Anand. Dr. Renay will be speaking on percutaneous closure for TEVAR and EVAR. And it is very important for us to be acquainted with the percutaneous closure devices. Dr. Renay, please.
Thank you, sir. After much complex talk, I am just talking on a much simpler talk. This is on percutaneous access for an EVAR or TEVAR. Myself, I am Dr. Renoy. And traditionally, all the access was surgical, but recently we have moved to much more easier things like percutaneous access. There are mainly two devices which are available in India. One is a suture-based device from Abbott called ProGlide, and a Manta device, which is a collagen plug-based device from Teleflex. Manta was recently introduced in India maybe around 1.5 years back, and Perclose has been here for maybe past 10 years or so. So ProGlide has got a large indication. It can be used anywhere from 6 French access up to 26 French as per guidelines, but any access more than 8 French needs multiple ProGlides. Maybe in some cases, certain cases, 9 French also we can manage with one ProGlide, but anything above, as per recommendations, anything above 8 French, we need multiple ProGlides. And Manta is a collagen-based device. And there are two devices available. One is 14 French and another one is an 18 French device. And for sheets ranging from 12 French access to 25 French access, we can manage with one single Manta. So this is actually, before going into the Perclose technique per se, most of my talk is actually based on suture-based device, that is the ProGlide's Perclose device. Before going into the talk per se, this is actually a busy slide which shows the average size of almost all the devices which are available right now. And you can see most of the devices lands in this 18 French to 20 French devices, especially those which are available in India. And some of the devices are coming up to 23 French and 24 French depending upon the size of the device. But as we see, most of them are 18 to 20 French. So we need to know what device which we are going to put and then plan our access as per that. So most of the main body device which we get are in around 20 French. Some of them can be 18 French and 16 French also. And TEVAR devices can also vary. It can vary from 22, 24 and 26 French and sometimes 18 and 16 French. So ProGlide, as I already told, the recommended size for a single ProGlide access, if it is an 8 French access, we can manage it with one ProGlide. And by norm, if it is a 16 French access, we need 2 ProGlides. And if it's a 24 French access, it is 3 ProGlides. But with experience, we can actually manage 20 to 22 French access with 2 ProGlides also. And this is the basic construction of a ProGlide. And before going into the Perclose technique per se, we have to prepare these patients. Most of our patients currently we are doing under local anesthesia if the patient is cooperative and if the patient is having multiple other comorbidities like COPD and prior coronary artery disease. Like that, in those cases we generally tend to do under local anesthesia with mild IV sedation. And most of the cases 60% of cases we still do are also under general anesthesia. But if the patient is under local anesthesia, we have to prepare these patients. And the first and foremost thing in a ProGlide is check and document the pulses before procedure. Because after procedure, if you don't get a pulse, then we should not confuse it with an acute occlusion versus a chronic occlusion, because most of the patients of aortic disease are smokers. And catheterize the bladder. We can give an anti-anxiety drug like alprazolam 0.25 milligram on the previous night. We give an antibiotic. Our choice is cephalosporin half an hour before groin puncture. And IV analgesics like paracetamol is given just before the procedure. Sometimes if the patient is very anxious, we start with the 25 mics of injection IV fentanyl. We also keep in hand atropine because most of these patients can have a vasovagal attack if they are done under local anesthesia. Mostly it is related to pain. So we keep atropine in hand. And for BP control, we give either IV labetalol or NTG or nimodipine. And adequate local anesthesia around the femoral artery is actually the most important key thing to reduce pain during the procedure. So what are the basic requirements for a perclose technique? You need at least a 6 mm diameter of common femoral artery, and the anterior wall should not have any heavy calcifications or any large plaques. That means at the puncture site there should not be any heavy calcifications or plaques, and you should keep at least 2 numbers of ProGlide for a TVAR and at least 4 to 5 numbers of ProGlide for an EVAR, 3 ProGlides in the side of the main body and 2 ProGlides in the side of the limb. Main body also can be managed sometimes with 2 ProGlides. And in addition, you keep all this routine stuff. So how I do is we give 15 ml of lignocaine on one side. Sometimes we may add a bupivacaine if we are expecting a quite long procedure. So ultrasound guided local anesthesia is given even up to the anterior wall of the close to the anterior wall of the femoral artery, and before going we put a liberal skin incision, 1 centimeter skin incision. This is a very basic step, and dilate the tract. This is actually very important because most of the time we face complications because we haven't dilated the tract enough and we could not take the devices. So tract dilatation is extremely important, and it is a very basic step. And once we dilate, this is actually most of the tract dilatation is done over the wire. After we take the puncture, we place the wire and then we dilate the tract. But for the sake of this, I have taken a picture like this. We do an anterior wall puncture using an ultrasound guidance, and our needle entry will be around 45 degrees, and we should avoid any area where there is any hard plaques or calcifications. Put a 7 French sheath, give 2500 units of heparin, and through the 7 French sheath, you take a thermo wire, your angle thermo or straight thermo, exchange length is preferred, and you can even take a stiff wire, and the wire is kept at the level of T10 usually, and deploy the ProGlide, first ProGlide. So the first ProGlide is inserted at a 12 o'clock position. That means the ProGlide is facing to the roof of the room, and then once it is inserted fully, when the blood jet comes through the side port, this is the side port, when the blood jet comes, turn the device 30 degrees towards you. That is the 10 o'clock position. That is the position where you complete the first 4 steps. That means the firing of the suture of the ProGlide, of the first ProGlide. So the first ProGlide is turned towards you, that is the 10 o'clock position, and the procedure is done. So you insert the ProGlide in 12 o'clock position and turn the device 30 degrees towards you, that is the 10 o'clock ProGlide, that is the first ProGlide, and complete the first 4 steps. Remove the ProGlide over the wire, reinsert the second ProGlide and turn it 30 degrees away from you. That is the second device. So 2 ProGlides are deployed, one is at 10 o'clock and the second one is at 2 o'clock. So these are the first 4 steps. I am not going to go into detail because of lack of time. So once you complete, so this is exactly the first ProGlide we have deployed, kept the sutures apart. You can see the sutures are pasted here with the steri strip, and before removing the first ProGlide, we will insert the wire through this port, and the second device is inserted, and it is turned to 2 o'clock, and the first 4 steps, that means the firing of the suture is done and the ProGlide is removed. So you can see the 2 sutures of the 10 o'clock pasted here, and the 2 sutures of the 2 o'clock ProGlide pasted here. These 2 sutures should be kept apart because they should not be tangled, because it may, once you get tangled, it becomes chaotic and the access becomes difficult, then it may, hemostasis may not be adequate. So once you put 2 proglide, put an iron French sheath and keep it ready. Similar steps are done in the left side also, and another 9 French sheath is placed. So now your pre-close is done. You can complete the heparinization, and then make sure the proglide is, the sutures also kept wet, because these are all proline sutures. They tend to break if they are dry. Proceed with your EVAR and TVAR, and usually the devices are taken with over the track before, with a 16 French dilatation done beforehand. And once your EVAR or TVAR is done, you have to close the closure access. So once your device is removed, we generally do like this. We don't do it over the device itself. Most of the experienced practitioners can do it over the EVAR or TVAR device, slowly tightening over while it is withdrawn. We remove the device completely and put a 7 French sheet. One of our assistant will compress the groin, and we start tightening the sutures of the proglide. The blue suture of the proglide is only tightened first. That means the 10 o'clock suture is tightened first, and then we take the blue suture of the 2 o'clock proglide and we'll tighten that. So the 10 o'clock suture, blue suture, tighten first, and then 2 o'clock. So now you have a 7 French axis. Now your axis is reduced to 7 French. Most of the time we will not have bleeding at this point, but sometimes if you have bleeding, you can upsize the sheath. You can, if it's a 7 French, you can upsize it to an 8 French or 9 French or 10 French, and then the bleeding will stop. That means your axis is now 10 French. You tighten the blue wires again. That means, and if this, at this point, if the bleeding stops, that means the entry point is reduced to whatever sheath you have placed now. And if there is still bleeding, if there is severe bleeding even after tightening the blue wire, that means you have liberality to put a third proglide also. Third proglide can be placed in the 12 o'clock. The previous ones are placed at 10 and 2 o'clock. If there is still very severe bleeding, you can call the surgeons. And if there is no bleeding, you remove the 7 French sheath and tighten the sutures. This can be done over a thermowire. We generally do it under thermowire or even a Teflon wire or any stiff wire. If there is a tortuous anatomy, we tend to put a stiff wire and then do it. A straight tip stiff wire is what we do. Blue sutures are tightened first, as I already told, 10 o'clock first and then 2 o'clock. Sheath is removed. Now it is being tightened over the wire. Once it is tightened, you remove compression and check for bleeding. If there is no bleeding, remove the wire also. And then at the end, once you remove the wire, if there is no bleeding, you can tighten the white wires. So the white wires is tightened at the last. So it is always 10 o'clock position of the blue wire and 2 o'clock blue wire. Remove the sheath, then tighten again over the wire, 10 o'clock blue wire, 2 o'clock blue wire, remove the wire, and then last white wires. Now if there is still bleeding over the wire, you can actually put another sheath, give compression, maybe a 4 French sheath is enough, and you can just give a compression and it will settle. If it is still bleeding, you can put a third proglide in the 12 o'clock position, as I already told, and or else you can use another collagen based device like angiocellular obtura. Once you finish, you cut the wires and check for distal pulses. Make sure that there is good pulses, and we tend to do an ultrasound at the groin also, because sometimes we tend to see if we may pinch the posterior wall of the common femoral artery. That is one complication which we get sometimes. And if the nick is very big, we put sutures at the skin site also. We remove it during the first follow-up, that is at 2 weeks. We continue the IV antibiotic for 1 more day and then shift to an oral antibiotic. Immobilization is usually given for 6 to 8 hours. And if the patient is stable, we discharge them at 24 hours. And a superficial ointment also is, antibiotic ointment also is given. The complications, the most common complication which we get is a femoral artery occlusion, because the suture bites the posterior wall of the artery. This happens if our angle of shooting, that means the step 2 of the proglide, that is plunging of the sutures, happens at a steep angle. If we are not pushing the plunger at a 45-degree angle, this plunger actually goes in and take the bite at the posterior wall. This will cause approximation of the anterior and posterior wall of the femoral artery. It will have femoral artery occlusion. It can be managed actually very easily. It may be very scary at that time. when you do an angiogram, it will look like this. There is an occlusion of the common femoral artery. Actually, there will be a tight occlusion here. You may not be able to pass wire very easily with just fluoro guidance, but if you add an ultrasound, you will know the teeth of that occlusion exactly. With an extravascular ultrasound guidance, you can pass the wire distally. Most commonly a straight thermo wire can be passed, and you
Last
can
2 minutes.
dilate with the 6 mm balloon, and it will look like this. Some cases we may have a rupture of the common femoral artery. This is a surgical indication. Thank you.
Thank you for a very detailed talk. That's very nice. Would you mind if I make a couple of comments?
Sure.
One of the things is about, we mentioned dilatation with an artery forceps, and I think that's very important. And I think what we do is to dilate that under ultrasound, make sure that your artery forceps open on top of the actual common femoral artery, because what you're trying to do is to disrupt the fascia that will prevent your knot from going on top of the artery wall. The second is the planning is very important, as you said. The small arteries are very difficult, calcified arteries. Also beware of very large arteries, which are more than 2 or more centimeters. Look at them on ultrasound. If they have thinned walls, they don't catch the sutures very well. And in which case we try to go down to the SFA sometimes if there's better quality. And if you are going through the SFA, try and avoid puncturing through the sartorius muscle, because you can never dilate the sartorius muscle to get the suture done.
Yep, I think any more questions from the audience? I think you demonstrated very well. Congratulations. That was a great effort that you've made to take out all these images and show it precisely how it is done. Anybody in the audience? Any one question that we can take and then we close? So if no more questions, I think we end the session here. Thanks to all the speakers. That was really wonderful. You kept time. And there was good participation from the audience. And Dr. Bashi, see the audience now. Just turn around. When we started, there were just few of us. Few of us were basically the speakers and the chairpersons. But now we have great audience who participated. Thank you again. And I think we go ahead with the next session. Thank you.
Time is up.
Can we have all the chairpersons and the speakers for this session on the stage, please? Sir. Just to freeze the memory of this session, can we have all the aorta stellars on the stage, please? One photograph, yes, sir. A big round of applause for our speakers and esteemed chairpersons. Moving on to the next segment, I would like to call on stage my mentor and senior consultant in vascular and endovascular sciences department at Medanta Hospital, Gurgaon, Dr. Virendra Shoren, sir, to moderate the session. And the panelist for this session, Dr. Avinash Gutte, sir. He's a senior consultant from JJ Hospital, Bombay. Dr. Rohit Nair, sir. Sir is a senior consultant in vascular and interventional radiology at Aster Medicity, Kochi. And Dr. Hemant Deshmukh, sir, who is the senior consultant at Department of Vascular and IR at MGM Institute, Navi Mumbai. Dr. Rohit Nair, sir. Two of you. I would also like to invite Dr. Girish, sir, to join the panel.
Dr. Rajat, if you are not tired, please come up. So it's just two simple cases. We'll go over dissection cases and good Q&A. Kamal sir, you can also join for good sake of discussion. Santosh, please come up. So it's basically a panel discussion where I have done a case which was recently done, and it's an interesting one, so I have shared it. So there's a call from an outside city by the treating physician who is an intervention cardiologist. Patient is a 46 years old male, medical officer, presented with acute unbearable pain in abdomen and upper back since few hours, and as the protocol is, they did an ultrasound and finally a CT angio was done, abdomen and then a thoracic. So they found it was a type B aortic dissection. The call which I got was through a cardiac surgeon in our hospital because he used to work there, that what has to be done. So this is the report, type B dissection routine report with the total diameter of the aorta not more than 30 mm. So these are the images for the panel. So early and delayed phase. There is dissection. The true lumen is still okay, I would say. If we follow the diameter rule, it has not, the total diameter has not crossed 40 mm and the false lumen is, I would say, less than 15. Patient with pain, anxious patient, what would be the, I'll just start one by one. So Rohit, how would you treat it? So there is a report and an image has been shared with you. Yeah. Pain, young chap, no history of hypertension, no history, family history of any collagen vascular, no other comorbidities. Yeah. So this is the image, and the only symptom is pain. In epigastric region and maybe upper back.
Yep, I mean, so going by what the talk which I gave and also as per those guidelines, given that there is no, and it's presumably is hemodynamically stable, this would be a clear case not to do anything and treat him with pain relief. And this pain relief, when we say pain relief, everybody just puts in sort of some pain relief which is given by anesthetist, but there's also a pain relief protocol for these cases with dissection, wherein you go into morphine and you can escalate it to a combination of morphine and the other phenergic pain medication. So that would be my approach. And then, as I said, second day if he's stable, 7th day follow-up CT and see the progression.
Yeah.
What was the BP when he presented?
So it was completely normal, 120/80. So the blood pressure was fine. So yeah, so he finally flew and came to our hospital because of the anxiety. But when I got the call and the images, that's what I told, young chap, basically little high profile being a medico. I also told go with a conservative. I was not even going ahead to look for a CT scan also, looking at the images and the diameter, but he shared. So these were the images.
So basically why I'm asking is, in case there is accelerated hypertension, then you would start him on a level.
Yeah, agreed, sir. But BP was completely normal. Rajat, what's your take? How would you deal it? And then Hemant sir can also comment.
It's quite interesting. BP is normal. That's unusual.
Yes.
Because that's the center point of conservative management, is to bring, maintain the high blood pressure. The one thing that rings alarm bells is the age of the patient. Does the patient have something like Marfan's or a connective tissue disorder? Because that's something that needs to be considered.
Yeah, that's what we thought. Hemant sir, any comment?
I think I also will continue with conservative management and best optimal medical therapy, what we normally call it, only if there is no mesenteric angina, no hypertension and no claudication. If these three things are ruled out, I think best medical management is the only outcome.
Yeah, agreed. So for the, Vimal sir. So when the patient came, I mean, the CT scan was done a day prior. So he flew, he came next day. Blood pressure was fine, no need for any hypertensive. But yes, he used to be awake whole night. So he was admitted with best medical, PCA pump, morphine, everything, but sitting all night. So that was going on. And then finally, I mean, there was a dilemma because blood pressure was not high, and then we went ahead with it was 5th day or 6th day with a CT angio because I had no other way to convince him. So why the pain is not subsiding in spite of best medical therapy? X-ray, how, sir? X-ray, sir. Yes, agreed. So that's how we had no other choice than to go with a CT angio. A repeat CT angio was done. Initially, I thought like I'll go with a PET CT just to see any inflammatory changes, but I went ahead, and then on the CT images, there was definitely in 5 to 7 days, there was slight change. The false lumen was expanding, although I would say not very drastically, but yes, there was change if you compare it 1 to 1. So previous, let me see.
The leak has definitely increased.
Yes. So the hypodensity or on the false side has increased. The diameter at some areas were 2 mm or 3 mm more on the false lumen side compared to the true lumen. But still, not to the criteria of complicated type B dissection where we can say we can directly go and intervene. But the only symptom was pain, still persisting. So now how will we take it? It's 7th day post-dissection, unable to sleep, mild changes.
So refractory pain is a feature of
Yes.
high risk uncomplicated. But even in the second CT which you showed, this probably was an intramural hematoma which then progressed on to being a dissection. The filling of the false lumen with the contrast, the intramural pools have become larger.
Yes.
So again, that's an indication for.
So there were two changes: persistent pain and mild increase in the diameter. So now we had no other choice. So he was like 41, acute onset. Any concern for spinal cord ischemia, and what would be the length of coverage? Any spinal protection to be done or not? If you're going for a T1.
This one, there was an interesting discussion earlier, and we keep arguing, and I'm also with Rajesh also. I am for putting the epidural spinal drains for all these acute cases. I'll tell you why. There's a major thing. I know there are a lot of people, about 70 to 80% will disagree with me, and we didn't.
No. So Rohit, I'll tell you a story. 5-7 years ago, we had a discussion. Girish sir is sitting here. I was presenting a case. He got up and said, "We don't put any spinal drain." So those were his words, and I was saying, "We put it." Even Bedi sir was against, and now he had 3 cases because I had 2 in the beginning. So our protocol is again, I am also very pro if there are no contraindications, because my neuroanesthetist is well trained, so you have to have a very dedicated guy. So we also follow the same protocol. If I think is a 41 years old chap, even a single stent graft can cause a paraplegia. And I have seen that.
I agree, because you see the study
So
which
this
everybody is
is
referring
for the audiences.
The study which everybody is referring to, the one which was done in Netherlands comparing putting prophylactic drains causing epidural hematomas, those were larger drains done about 8 or 10 years ago. Nowadays they do it with the 2 French system. So I'm for it.
The question is not whether to drain or not. The question is to whether, if the patient has paraplegia, you have to use a spinal drain.
Yeah, that
the
is
question
for
is
sure.
whether you use a prophylactic drain or whether you use a drain if the patient has paraplegia. So in my head, if you have facility where you can get urgent spinal drainage if the patient goes into paraplegia, then you can wait for that. Big centers have that, they have got anesthetists who can put quick spinal drains. But if you don't have that, then you're better off doing a spinal drain. And then you're looking at the spinal cord supply. In my head, the spinal cord supply has got 4 zones: the subclavians, the thoracic intercostals, the lumbars, and the internal iliacs. If you're covering 2 or more zones, you have a high risk of paraplegia, and then you're better off either prophylactic or treatment level spinal drains.
I agree, because you'll have to judge according to the facilities available in a hospital. Because if my neuro intervention guy, the anesthetist is not available, when it develops a paraplegia, then it becomes a pain. It's not easy because we work on a cardiac anesthesia side, so they have a tussle. I have to request each time, and so you have to figure out how it works in your hospital. That's the takeaway message. So we have aorta specialist from Singapore as well. So sir, your comment. Give a mic. Right there. Len, can someone help?
Yeah, has been also a controversial topic in Singapore. So increasingly we are moving away from prophylactic lumbar drain. But having said that, recently we just have a case that we didn't put the lumbar drain and got a paraplegia. Having said that, in those days when we were putting prophylactic drain, we also have patients with paraplegia, which means that the lumbar drain is not a guarantee that you will not get paraplegia, which is again also, and we have also had patients who developed paraplegia and we put in the lumbar drain and it didn't do anything. So I think the evidence for this lumbar drain in spinal cord ischemia, the evidence is not strong. Many of these are, I think at best anecdotal. I don't recall any randomized studies and so on. So personally, I think when the patients are younger, we tend to be more careful, and for what it's worth, we'll put in a lumbar drain. But for the older guys with a lot of comorbidities, especially nowadays, they are on dual antiplatelet or even anticoagulation. Those we tend not to put in the lumbar drain, because if we get a bloody tap, we can't give heparin, and then the procedure has to be postponed. So for those, we tend to be prophylactic. I think the other consideration is like what he said earlier. If you're covering more than 2 zones that are supplying the spinal artery, then we tend to be a bit more careful with that. But at the end of the day, I don't think that we have a definite protocol. A lot of times it depends on the case itself. There are some cases we feel insecure, we tend to do a prophylactic. And then there are other days where we somehow feel gung-ho and we don't put the drain. So
thank you. So it's a global gray zone. So we have to decide as per, customize as per the patient and our gut feeling. Okay. So we went ahead and we placed a stent graft, and believe me, it was, it's putting a stent graft, next day patient sleeping, makes you happy. So a stent graft was placed, the pain went away within 12 hours. Next day in the ICU, he was sitting completely pain-free. There's a drastic change. So sometimes, the guidelines do say that pain or intractable pain is an indication, and we should respect that this was the case for that. And I just requested him to send a video. He just sent it now. Volume? Yeah. Volume. I don't know. So what he was, he was driving, so I told him if he can send a video. So he just sent it like 10 minutes ago. I placed it. So he's saying the similar things what we discussed, that there was a pain in the epigastric for 2-3 days which didn't responded, upper back, and then finally as the stent graft was placed, and then we discharged him after 2-3 days of workup for collagen, vascular, everything. As of now, completely fine with stent graft. So this is one indication I wanted to discuss. We should not take it lightly. Yes, Dr. Pradeep. Mic, please. The mic, okay, video.
Yeah, it's a very controversial thing, because we have been involved in at least in a couple of cases, and one patient, the same indication, we kept him in hospital, waited for 7 days, 8 days, no significant change, because this is more of a IMH with some kind of bridging towards dissection rather than a pure dissection.
Yeah.
Youngish patient, so like you, I think we were pushed into doing the procedure, which we did, but I'm afraid the pain didn't settle in him.
So it can happen. I'm
so
not saying.
We were kind of
that's why
stuck.
Yeah. But what would we do? Just conservative?
I don't think any of us have an answer for this.
Yeah.
Was all of the dissection covered by your stent?
Sorry?
Was all the dissection or the intramural hematoma covered by the stent? Or
Yeah, I think ours was almost going to the celiac, distal to left subclavian. So with probably one stent, we were able to get the significant coverage. And
so that's a very interesting question.
Was there a lot of thrombus in the false lumen?
No.
Because sometimes the thrombus is quite inflammatory, can cause persisting pain for a little while.
Like in a similar, it was more of an IMH with thrombus, and it took almost like 3 weeks. And we don't know whether we should discharge him from hospital or we should just keep him in. And he's sitting there, the only thing is the pain, nothing else.
Yes. So Dr. Vimal?
Question is, why is this pain? Is it the pulsatile nature of the false lumen expansion that is taking place?
I think
and widening?
Combination of all, inflammation, expanding pain, because how would a stent graft decrease the pain? Will be the expansion and the pressure, I think.
So that's where Rajesh's point comes in, that in your case, probably the whole segment was covered up nicely.
So IMH was still celiac, you're right.
Yes.
And then we were debating, young chap, shall we cover entire in the one go, or I'll put the first one with the major two entry tiers and then wait. I have explained patient, if required, I may have to put the second one because it's all percutaneous. I can go ahead and do that after maybe 2 weeks. So that's another question which Rajesh raised, how long the stent graft should be.
Yeah, entry tear very clearly. You cover that and see if it decompresses the whole thing, and then you might get away with only one stent. But if you can't see the entry tear, especially in IMHs, then you end up having to cover the whole thing.
So yeah, it becomes very risky. So now there's a video. That's why I bought this video. I thought nobody will.
My name is because of Dr. Virendra Singh.
What do you
so
think? Why caused the
Hospital
dissection?
because
still it's a dilemma. He's completely. I mean, no comorbidities. No comorbidities. Maybe some collagen vascular subtle. I don't know.
My scenario is I got severe abdominal pain in periumbilical and shifted to the umbilical region and epigastric region. And I rushed to 2 to 3 gastroenterologists, and they suggest me for sonography, and sonography, X-ray, all are normal. Then CT, abdomen, and aortograms diagnose me as aortic dissection. And that time I am very depressed, and I am rushed to Medanta Hospital to consult to Dr. Virendra Singh Soren sir. And after consultation, sir removed my all fear about the TEVAR operation. And after operation, there is 2 stent is placed in my abdominal aorta, and I feel 0 pain, no stress, and no any.
So basically, the pain went away. That's what I wanted to show. I mean, sometimes, yeah, it may be tough. So now the second case.
Just a quick question about that. Just he had pain, persisting pains, which was an indication for treatment in his young guy. But the timing is a question. Ideal treatment is after a couple of weeks of onset. So did you wait for that, or did you carry on with?
So Rajesh, initially when we started practicing, 14 days was a norm. Slowly, now it's how it's going on is even. I mean, how the boundaries are pushed. So a dissection cane comes. Now the dissection is being done by ICs, by cardiac surgeons. The industry is pushing. As soon as they get a dissection case, it goes everywhere to each proctor. So now, doing a dissection, we have now good number, which has been done less than 7 days as well. So I don't know, still we follow the guidelines of 14 days or not, but there's ample of cases which we have done now within 7 days to 10 days. So in such scenarios where there is no other option left, probably I don't know whether to wait for 14 days or we can go. Because when you call it a complicated dissection, we still are doing in 2 days as well for a malperfusion. So I don't have an answer, and I'm pro. If required, I go ahead.
This was a refractory pain, so it is complicated.
Yeah.
So it can be done.
That's a point. Can be done.
Normally, what we follow is that we do a repeat CT. And at any point of time, we see it worsening, like there is visceral involvement or increase in the size of the leak or the dissection. increase in the false lumen, that's the time otherwise, ideally speaking, I would wait for 14 to 21 days before intervening.
Yeah, you're right, sir. If there are no symptoms, I have seen CT scans completely normal after 4 weeks with a huge dissection as well, like a good sized false lumen. With conservative management in 4 weeks, you can't even say that this patient had a dissection. So conservative management does have a role. I agree. So now let's go to.
Sorry, sir.
Yeah.
Did you place a drain in this patient?
Yeah, I did. So I placed a drain.
Even for such a short coverage?
So I
with patent left subclavian.
Yeah,
okay. Still,
I did. Honestly, I did. Yeah. So being a doctor, as I told you, 45 years. I mean, I thought if I was he, I would do same for myself, and so I did it. Yeah, it's very hard because once he developed, I have seen a single stent graft leading to a paraplegia in a transaction case, and we could not do anything. So it can happen because the patient came with a trauma. There were fractures in his leg, and he was not moving properly. And after the transaction, we placed a small 15 or 10, I remember, and it's now lifelong paraplegia. So you'll have to balance. I don't know the answer. So this is a case, again a young chap, unbearable pain in abdomen since few hours, came early in the morning to triage. Basic labs, USG was done, mildly raised LFTs. USG was reported normal. Patient is lying in the ER, a busy ER as it is always, not responding to medication and slowly increasing. As we all do, a chest X-ray, standing, supine done, unremarkable. Labs were kind of unremarkable. This is early in the morning, 5 a.m. And then a report came around like 10-ish. Patient still in triage, pain in abdomen, workup. So, I mean, nothing wrong with the ER guys, but finally a CECT abdomen was ordered by the gastro guys. And I'll go quickly. So this is what it was around 12-ish. So 6 hours lost. So this is a reconstructed MIP. Santosh, anything you can see?
It's a highly compromised true lumen in a type B dissection.
Yeah. So celiac and SMA we can see chunked out. Nicely filling though, but now only abdomen they did. So what would you advise next?
CT aortogram.
Yeah, so complete CT angiogram was done, and then the dissection was at the arch level, just close to the subclavian, and then retrogradely going into the arch as well. So the question would be here, this is the axial section. As we all see, always the pressure on the false lumen side is high and the true lumen is completely narrowed, and then you can see the celiac, the flap right there. So dynamic flap is there, and probably that is causing pain in abdomen.
Where was the entry?
So just close to the subclavian, very, very close. Why? But retrogradely it was going up to the ascending. So where does this type of dissection fit? Yeah, so it's a non-A, non-B type of dissection where they have made it configuration 1, 2, and 3 depending on how the dissection flap extends. One should be aware of this non-A, non-B because the treatment needs something more than just a stent graft lot of time. So type B with retrograde arch extension, arch entry and isolated arch involvement, arch entry and integrate into the descending. That's how it is. And then just to go over standard dissections, one should be aware of DeBakey's classification and Stanford classification. I won't go over that. And one more thing which is important, which is a very nice classification depending on the type, entry tier, and malperfusion. So TEM classification, which is, I would say, more prognostic-wise better than, or it's a combination of other dissection classifications. So let's go back to our case. So pain worsens further. And luckily the labs were sent, and now you can see the difference. Look at the SGOT. So the time has been lost in ER. So the reference to vascular or the cardiac surgery side was not given at right time. And now everything is... Sir, he came around, the pain started early in the morning, like first lab was, I would say 5 a.m. or 6 a.m. and the next one would be around 11. So it was so fast, so fast.
It was 3 days. 3 days.
Yeah. So, no, that's where I took a snapshot. The timing is a snapshot timing. No. That I took for presentation. Yeah, so from which they stopped now. I can't even do that. So that's okay. So now the thing is, the cardiac surgeon has seen, as we know, there are not many cardiac surgeons available for dissection, and most are not opting it as a carrier as well. So that was a question I wanted to really ask Dr. Bashi. He left. I have very close friends. Yes, sir, please. It's so hard to find a dissection dedicated cardiac surgeon. Yes. Yeah.
We have had patients with paraplegia.
Yes.
Patients with limb ischemia, even with threatened limb.
Yes.
And most of them were on type A dissections.
Yes.
When the primary tear was fixed, it was fine. Even when you had a patient with type B, when we put a stent graft, we opened up the true lumen. And the moment we see a good flow in the celiac, we stop there. In case you don't see a good flow, then try to go and do a stent, because already the true lumen is very much compromised. And just putting in a stent, then you have to do a fenestration, try to get from the false to the true. So you're making it more and more complicated.
I agree.
If you can do a quick job, open up the true lumen. If it opens, the celiac improves, it will be fine. Otherwise, if it doesn't open, then go for the secondary one, rather than fixing the primary one first.
Yeah, so primary tear seal definitely helps. In this case, I just forgot, it was involving the arch as well. So I'm really sorry about that. The flap was going anteriorly as well. So the decision was taken that the patient needs an FET for sure. So it was not a simple distal, I would say, entry tear to subclavian. So the dilemma was now whether the patient should go for an arch surgery, FET, or you do something because the malperfusion is now at peak. So in such scenarios, Rajesh, how do you go? So consider a scenario where patient has malperfusion, needs an ascending and an arch replacement, and for the treatment for type B.
I mean, again, obviously, he's a very young patient.
Yes.
So you'd look at what kind of collagen diseases he may or may not have.
He was hypertensive, yeah.
So the primary treatment for this is surgical.
Yes.
As a primary modality. But the lower down in the abdomen, once the top end is treated, and then you try and figure out what's happening at the bottom. The biggest problem, as Murali was saying, was to get into the proper true lumen. The problem arises when your target vessel is arising from the false lumen. So if you're trying to stent it, how do you stent it? Because you've opened up the true lumen, then how do you stent it? Hopefully the theory is that there's an intimal tunnel which just falls down in place when the true lumen is open. That if that doesn't happen, there are cases where we had to try and stent, that's not worked, then they had to put a bypass onto it as well. So all options are on the table. Young patient, there's no one treatment that fits it. So I think you try one after the other.
So most of the time when such scenario happens, the cardiac surgeon will not go for an arch surgery because he needs a patient to be alive. His case will be pretty long. It will take time, and by the time intestine dies, so makes no sense. So in such situations where you don't have an option of putting a stent graft from a primary entry tear, that's what sir told, that option of fenestration and increasing the flow into the true lumen, which used to be done when off-the-shelf devices were not available, is an option. So just to go over, this is frozen elephant trunk, where the arch is replaced, and then the device itself has a stent graft which is placed from the arch retrogradely. It is called frozen because earlier it used to be without the stent. Now there is a stent, nitinol stent is there, so it's basically frozen. So there are different configurations of frozen tent. Their Nexus and other devices are available which can be used as a solution. We don't have an experience, but people are aggressively using it, and probably time will tell. And this is a case from Dr. George Joseph, who does complete endovascular arch replacements with his expertise and physician modified. So these are the options which are available on endovascular side and the hybrid side. So just questions to Dr. Murli, advantages of FET in such scenarios.
I'll just answer what usually Bashi says. He tells it's an anatomical replacement. The results of FET are equal to an open aortic arch surgery where you get a perfect anatomical replacement. He prefers to use the thermograft, the largest, not the other one. Evita has used a few cases,
yes,
but they prefer nowadays the Thoraflex. And I know they do the whole thing skin to skin within 3 hours.
Yeah.
That is the sort of timing they finish the whole thing.
Unless you have to repair an ascending,
ascending
and the valve.
Even there, the FET time, when we started the antegrade deployment, it used to take around 6 hours for the whole procedure. And as their experience grew up, you know, the assistants all become so good. They'll get the axillary perfusion done within 30 minutes. By the time he gets in, 45 minutes, he'll finish the whole thing within 1 hour and come out. So their timing is pretty fast. 3 hours, 3.5 hours, he is out. So again, it depends on the expertise. But again, doing a FET for a beginner, it's not easy. It usually takes a long time, and at the end of the procedure also, they can face a lot of complications also.
So that's how it started in our setup also. First case, I remember 8 hours. Now he's done with 3.5, yeah.
In fact, before the era of FET, I remember in long back when I was in Ramchandra in 99, the cardiac surgeon K.R. Balakrishnan told, I'll open the aorta for you, you put this stent, I will stitch it. I thought he's telling something crazy. So I used to run away from those things. And now we know the FET is there. So we used to do the graft which Dr. Kamal showed in his talk, where you put the endovascular graft first and then try to stitch it. Even before the FET, we have done almost around 20-25 cases of this antegrade deployment of a stent graft and then suturing it to the arch graft, a branch device. Even those surgeries also, they used to finish within 5 hours. But now with the FET, life has become very easy. And for them, the surgical thing, even a complicated type B dissection, they'll straight away go for a FET. Because they feel they can anatomically replace, because sometimes we don't get a proper landing zone, then we get into trouble.
Yeah.
Again, expertise matters, I think.
Thank you, sir. So again, I mean, this is FET versus PMG. I think FET is off the shelf available and should be considered wherever there is an expertise. So the answer is pretty clear. Physician modified, I've seen Dr. George Joseph doing in 2 hours. I mean, he has really expertise there, but still endoleak and all that. So it's not a complete anatomical replacement. Yeah, and they come with retrograde. So whenever available, a center with an FET backup, I think FET should be preferred. Role of IVUS, Hemant sir, Rohit, how do you see role of IVUS in aortic dissection, and how often do you use and when?
Actually, I have never used IVUS in AED, but
Okay, sir.
once when I had a ruptured aortic dissection, I used echo, that is TE probe, and then could differentiate between the intimal flap and the true lumen, because it was very difficult. The intima was floating around, there was blood in the pleural cavity, so TE worked much better than IVUS, and I have never used IVUS.
The current consensus is to try and use IVUS as much as possible. First for in situ appropriate sizing of the stent, and also post stenting to look at any tears at the proximal and sealing zones. So they are all suggesting IVUS, but I don't have a
access to the true lumen also.
Access to the true lumen, yeah. And I mean, in our institution we use aortoscopes, which is also will show you the entry tape, but doesn't actually show you because there's a lot of blood, so we don't see it very clearly. But I mean, the IVUS, I think, is something which I think generally the IRs are a bit behind in catching up in the IVUS. I think
because it's not freely available to every one of us. Rajesh, how do you guys do in UK?
I've never used IVUS in dissections. I've used IVUS in venous disease mostly, to be honest. So
Right.
no experience. It's still starting.
Sir, how it is in Singapore?
Yeah, I used to poo-poo IVUS in dissection until I deploy one in the false lumen. So currently we do it for the more complex one, especially those with multiple entry and re-entry there, where we are not sure how the guide wire is going. So for those cases where we can confirm very clearly that we are in the true lumen, chances are we don't tend to use IVUS. The few cases that I use IVUS, the problem is that especially the chronic ones where the diameters are big, the IVUS can't see that far. So it's not that useful, I find. So it's only in cases where I really
need it,
couldn't tell that where my wire goes, that I bring out the IVUS.
So one quick question, your measurement, because when you measure on IVUS, on CT, there is a discrepancy, always. So how confident people are measuring on IVUS is a dynamic, but there is always the diameter when you measure, there's slight difference between your CT, a static diameter, although we oversize it, but then I don't know what's the answer is. Measurement on IVUS versus measurement on high-end CT angio. Pradeep, you wanted to say?
Viren, I think we have in-house IVUS. We have used in couple of cases. I think it is hit and miss. I think it may actually prolong your procedure time sometimes. So to specifically target a question, we might use like very high serum creatinine. You don't want to do too many runs. You just mark the left subclavian or renals, whichever aorta versus dissection. Sorry, aneurysm versus dissection. Whereas I think our standard practice now with very good surgeons with us for the type A or retrogrades is FET. I think no questions asked. Just last week they have actually done a postpartum lady with an acute and chronic dissection. So we get involved in putting the wire through the true lumen using a transesophageal echo, and then we antegradely deploy the stent and they suture. So now I think we have very well adjusted pattern of working as far as that one. Whereas IVUS we have in-house, but I have tried in peripherals and also in dissections or in aneurysms. We use only for specific answering the question. So otherwise it just adds the time to the procedure.
Got it.
So one quick question. Between a cardiac gated CT angiogram and IVUS, where precision is very important, what would you choose in your expertise?
So I don't know the exact answer, but as every one of us is on the same boat, IVUS is hardly used, so most of us still believe on ECG gated CT measurements. IVUS is selectively used wherever required, so I don't know whether we'll be really jumping, because I still remember during my training days when the vascular surgeons in US used to have, so they had a C-arm, so there was a limitation on fluoroside, so they used to use IVUS, so they were really trained on IVUS. So it was done in an OR with a C-arm, and they used to do IVUS, measurement, everything, and on C-arm just deploy the stent and come out. So it depends on what is available, how your expertise is, your time consumed, so a lot of factors. That's what I think.
Is with the IVUS that we all use it infrequently in some cases.
Yeah.
It does have a learning curve.
Yes, it does.
So at the beginning of our learning curve, we're probably not that good at it. So I would fall back on CT measurements at that stage. That's my fallback option.
Yeah. So let's go to next question. Role of diagnostic lab. So whenever a patient with mesenteric ischemia with labs so raised, and the cardiac surgeon wants to go for a Bental arch replacement, so what's the protocol? Does every patient goes for a diagnostic lab first to see the intestine status? How's the protocol, Giri sir?
Of course, we clinically examine the patient. That's most important. Tenderness, lactate levels. These are the things that we check. And if at any point of time we feel that there is some amount of significant bowel ischemia, because the CT may not show it.
Yes.
Of course, if it is advanced, CT will show it with bowel wall edema. You can even have hemorrhages. But if the CT is done too early and it's not showing it, then clinically is the only way you can. And if you have the slightest doubt, I think laparoscopy is a must.
Yeah, I think again it's a gray zone where as we talk about whether we should prophylactically place a spinal drain or not. So this DL is almost like, I would say, whenever we open an acute limb, either endovascular or open, so there is always a dilemma whether we should go for a fasciotomy or not. And next day we repent like why was it not done, and sometimes it's like why did we do it. So it's again same. So there is always a debate. So I don't have an answer, but Pradeep has some.
No, I think we had this extensive discussion in Hyderabad, if you remember, sir. I think the cardiac surgeon's view is if there is
gangrene,
any doubt, they actually don't want to open the chest first.
Yes.
Because they have faced that mortality is so high.
Yes.
So if they have any doubt, they want to exclude the bowel.
So as of now, the call depends on them. That's what is the protocol in my. So unless and until he is convinced, he'll not go for a thoracic surgery. So most of our cases, I'll show you what we did with this case.
There's just one question. If the cardiothoracic person is not involved, in the sense that you don't have to do an arch repair, the call is yours.
Yeah, agreed.
So then, who takes that call?
So sir, unless and until I would say a patient comes to me directly, and again it's in dilemma, I am answerable to the family. It's a gray zone as you told. So probably I'll go with DL because it does not take much time. So that's my call, is because it becomes, even though we are doing an endovascular, which is not a very time consuming procedure, but yes, it does involve finances. So if you have done TWAR, you have done a procedure and the patient doesn't survive, so in a setup like ours, it's not easy to convince the family why it was done before and the patient dies of mesenteric ischemia. So it's a tough decision. I am pro DL whenever I feel I am not able to rule out on imaging and clinical and labs. And this is a question to Dr. Girish sir. Shall we aim to seal only the primary tier or cover all the re-entry tiers as well? So what's the,
There's a big debate going on this worldwide also. But the earlier trend was you primarily treat the entry tear. But now they are saying that we have to do re-interventions for the secondary, the re-entry tears. I think a dissection is a thankless job to do. So I still personally feel you treat the entry tear only. And as and when you have a problem with the re-entries, then you treat it then.
Hemant sir, your take?
I'll go by nature. That is when you seal the primary entry tear, all other abnormal tears should close down because you're opening up the true lumen and you're closing down the false lumen. If the re-entry tear is still open, that means the entry is still not adequately closed.
Okay. So now, I mean, in our case, so the dilemma was what to be done first. And in such situation, this we have, I think, discussed spinal cord ischemia. One question for subclavian, I think we left this. So how, I mean, in questions to those who covered subclavian, or if it is required to cover a subclavian, do you all do pre-fen or you put the stent graft and then do an in situ fenestration? Let's start with Singapore experience. Yeah. Mic. They don't have mics. किसी को बोलो. Bully sir, ask them to,
Yeah,
4-5 mics.
We don't have much experience for in situ fenestration. So typically, if we can avoid to not cover the LSA, we try not to. If we have to cover, typically we would just cover and we'll react if they have symptoms and all that. In the more elective cases, we try to do the intracranial imaging to make sure that the vertebral artery, if the left vertebral is dominant, then I think we would try hard to revascularize, like a bypass before we cover it. Otherwise, I think if we can avoid, we would avoid. If we can't, we would still proceed, but monitor closely for, I guess, the upper limb symptoms and do the bypass on demand, so to speak. Yeah.
Sir?
I am a firm believer that you don't cover the subclavian. So I prefer to do it, open the graft, make a fenestration, suture a wire around it, and then recapture it and then do it. Single vessel is not an issue at all. When there are multiple branches, then is an issue. The other most important thing is that you should never forget that if you have a fin for the subclavian, you have not lost an option of entry if you have to do re-interventions. So you have the subclavian open where you can do it. Lastly, the only time I've done an in situ fenestration was recently, where there was a young girl who had a vehicular accident, had a aortic transection. Her aorta was small. We didn't have a covered stent, a stent graft that size. So what we did was we used 2 Bentleys, and for that I did not want to not have a fen for it. So that's when I did an in situ fenestration and put a Bentley in the subclavian.
Rajesh, you want to comment?
I think the left subclavian should be revascularized if you're covering it. Not only for the vertebral artery reason, but also for the fact that the internal mammary artery has collaterals that feeds the spinal cord. So that reduces the chance of spinal ischemia. So in our center, we don't have experience with physician modified grafts. So we would, if we are covering the subclavian for whatever reason, we would put a bypass in the past. But these days we have started using the Gore TBE device to get it in. Of course, if when you're in a very complex dissection situation, I wouldn't recommend trying to snare things and all that. You're better off with a bypass maybe. But that, I think it should be revascularized though.
So the consensus is, if possible, we can and we should. So coming back to our case, so what we did was, so we planned to reperfuse mesentery, do a diagnostic lab once we had reperfused, and by the flap fenestration. This was before the aortic surgery. Yeah, so no, so what, simultaneously we did both, but doing a fenestration doesn't take much time. So what usually we do is, we do a fenestration, as soon as we are done, the diagnostic guys do a lab, and then the patient goes for a thoracic surgery. You can do the other way around also, but then you losing whatever time we have in fenestration, doesn't take much time, the flap. So that's how we have done 4 or 5 cases whenever such dilemma had come. So you can see, just to show the chinked out, narrowed, so this is mag view, there's a dynamic flap right here at the SMA ostia. So what we do is, you take an axis from both the sides. This is true lumen, you can see, although on the MIP it was looking really great, but look at the flap, which is dynamic, so hardly any flow is going into SMA. So that's just a wire and a guiding catheter. And then here the role of, the IVUS is very important. It can be done without IVUS, but IVUS gives us some more confidence when you are doing a fenestration. During my training, we used to use Pioneer, which is really an IVUS guided re-entry device, which is very helpful, but we don't have that. So one wire in the true lumen, the other one is in the falls, and then IVUS guided. What you can do is, you can take an angled catheter, even a back end of a 1/4 wire. You can see the flap, so your catheter is right there, and then you just direct your catheter towards the flap. So from the true, you are fenestrating into the false lumen. So you can see here, and then you can take any sharp CTO wire as well. So it goes very easily, and the IVUS is right there to guide you. And once it is there, you can see that your catheter is inside the false lumen now. And yeah, so this is true. So now you, over the wire, you can just put a TUI on your guiding or a sheath, whatever you want. You can just see where the fenestration you have created. And then you go with the largest balloon or whatever, 16, 18, 20, whatever you want to fen. And believe me, ballooning doesn't help most of the time. Again, the flap will come. So better to take a largest venous stent, whatever, Sinus, XL, Vinova, whatever you have on shelf. and then just place it across the fenestration you have created. I know it causes future problem, but now we have to tackle the acute condition, and then you can see the true lumen filling nicely. It has depressurized, and you can see the changes which happen. So this is something an intervention radiologist should be aware of, and at time maybe once in a lifetime will be required. So you can see on IVUS here, you can see now the true lumen is depressurized, and false and true lumen both are almost like equalized. So this is one, yeah, that's the flap, nicely seen, where the true lumen was initially almost sitting on the catheter. So ideally it should have been done like this, but we ended up like this, and patient survived. And then he went with his surgery of the ascending, so he replaced the arch. So just I'll complete the theory part to finish acute dissection. So uncomplicated, we all agree, patient has no symptoms, so we should wait and watch. Girish sir has commented 2 weeks, 4 weeks. The dissection part does resolve. Whenever there is a complication, now there are guidelines with level of evidence and recommendations that endovascular is a preferred approach, or hybrid is the way. Whenever there is a rupture, malperfusion, extension of dissection, so a lot of criteria are there available. And for uncomplicated, again, we have good guidelines we should follow. So our patient was here where the refractory pain persisted more than 12 hours despite maximum recommended or tolerated dose. So persistent pain definitely is one of the high risk clinical finding and should not be ignored. And just to say that now we have a class of recommendation 2B in patients with uncomplicated acute type B dissection who have high risk anatomic features, endovascular management may be considered. So slowly the guidelines are getting better and better and in favor of endovascular. So I would like to end my talk here, and thank you so much for discussion. So there is one case, we have 10 minutes left, she wants to present.
Good morning everybody, and I would like to thank Dr. Murali for giving me this opportunity on such a short notice. So I have a patient who was working as a general surgeon in UK, and in 2010 she was doing a surgery in the middle of the night, and she looked, and at the end of the difficult surgery she looked up at the anesthetist and told him it's over, and immediately she felt a very sharp pain in the chest. So later on, the same night she was evaluated, and she had a dissection from the ascending all the way to thoracic aorta. So they did the open surgery for her from the sinotubular junction till in the ascending aorta. They have put a Dacron graft, but inadvertently they had closed off the left coronary artery, so which they realized later when she complained of pain and the ECG showed changes, and they had to transplant the left coronary artery into the graft. So post-surgery and further investigations from 2010 to recently, everything says that the dissection is extended throughout from the surgical site, from distal to surgical site, from the arch at the level of the origin of the brachiocephalic trunk till the aortic bifurcation. So now at present, it has been slowly growing. At present she doesn't have any pain. She came to me because she was getting recurrent strokes involving the left side of her body, and when I analyzed her MRI, it was all hypoperfusion infarcts. Now, she also has a dissection in the brachiocephalic which arises at the origin of the common carotid, and I have seen it on ultrasound as well. I am not able to find the distal extent of the dissection, because when you analyze the CT angio findings from the distal cervical ICA to the intracranial circulation, it is there, they have to put it. Can you please put it? I don't have all the images, so the intensity of contrast is very much diluted. no, not this, start from the last image. So this image, we can see that the right common carotid, you can see the dissection coming down, and then there is a thrombosed false lumen. And the false lumen is aneurysmal. Can you show the whole thing and go to the next video? And the false lumen is partially thrombosed, but it's majorly thrombosed. And when you come towards the distal thoracic aorta, the true lumen is significantly narrowed. And the celiac trunk, I don't have the images, the celiac trunk and the right renal artery are perfused from the true lumen, while the superior mesenteric artery is perfused from the false lumen. The left kidney is atrophic because the left renal artery is completely occluded. The dissection extends till the aortic bifurcation. The left common carotid is normal, the left subclavian is normal, the right subclavian is normal, and when you see the right vertebral artery, in the cervical segment, there are multiple aneurysms intervening from the foramen transversarium. So when you see the brain, the contrast on the right, the intensity of contrast on the right is very much less compared to the contralateral side. There is an ACOM, but there is no significant flow across the circle of Willis. So her right brain, we can see I've seen the MRI as well. I don't have those pictures here. The whole cerebral hemisphere is ischemic, more so in the watershed territory. The patient is intellectually normal. She is ambulant, but with she is able to walk, has difficulty climbing the stairs. And this all started in 2010, and I'm seeing her now. So can you show the further images, please? So the false lumen extends in the proximally from the origin of the brachiocephalic trunk on the aortic arch. Yes, she came to me because she had multiple strokes and she has gone to multiple people, and there is a dissection in the common carotid.
No.
There is a dissection in the common carotid. No.
Till what level?
So the distal, I have even seen on the ultrasound, I can't make out the distal extent.
No. Is the distal common carotid okay?
No, it is dissected. The common carotid?
You can do an IVUS or something to find out the distal limit. Unless you find out distal limit, the dissection is going.
If there is a normal segment, then easiest thing will be carotid bypass. Tide over the crisis, then any of this aorta needs to be corrected.
I have discussed with the cardiothoracic surgeon also, because we're thinking of anastomosis between the carotid and the carotid subclavian. Because of the dissection extending there, he was not so okay with it. So he was telling about the axillary and the right axillary and the left carotid bypass, but which, if we can do a endovascular repair, we can actually fenestrate that and put a graft. So the right common carotid is dissected, and the dissection extends into the ICA. And I think at some levels, when I see on the CT, I'm not very sure, but I think there is a small dissecting flap even at the petrous segment, but the flow is there. But I think the major dissection is in the neck, both in the CCA as well as the ICA.
In spite of dissections, is there good flow in that vessel? No, because if she is getting a stroke in spite of good flow.
When you see the CT angio, the intensity of contrast on the right side is very much relatively, significantly lesser compared to the left side. So she is getting recurrent strokes because of the hypoperfusion on the right side.
It's either that or she's embolizing from the false lumen. That might be the cause of the recurrent strokes. So the important thing is to make sure that
MCA, ACA and the MCA, PCA watershed territories are infarcted. And on the right cerebral hemisphere, there is the white matter shows diffuse T2 flare hyperintensity. So it's mainly hyperperfusion, because you can also see that the intensity of contrast on CT angio is significantly less, which tells, and the flow also is delayed, and it till the brachiocephalic, till at the level where the subclavian comes out, it is fine. But after that, the intensity suddenly reduces.
See, maybe.
And I can see the flap in the ultrasound here, but I can't make out the distal extent.
So that is what Raj was saying. So I think the first thing to do is probably to get the flow dynamics correct. Is that you may have to do an angio first to see what's happening. I mean, you can't. I don't think you can deduce from any good left. Maybe. I was, yeah, but the only thing is she's saying that we cannot. How far into the? So you can do a DSA.
But she's saying going up to the ICA, no, may not be in the petrous part, but at least.
No, yeah, that also is true. You can do that also. I was thinking if you do run from the left CCA, you might be able to see what is the cross. Can you make out the cross circulation?
On the CT angio, I was able to see the ACOM, very small ACOM, but it is there. It is not very big. But I could not, if ACOM was very good, we could have seen the flow from the left to the right. But when you see this, can you please show the CT angio axial pictures?
So I mean, I don't do any neuro intervention, but then don't you guys compress the other side and check?
No, actually,
you don't do that?
Actually, if the flow is definitely reduced, then it may not help. Otherwise, it would have.
No, my question was whether there's enough flow from the opposite side.
Can you please run this as well? Can you please
No, the very fact she is having hypoperfusion, that means it is inadequate. You need to revascularize.
Correct.
The question is how to do it, whether it is surgical or endovascular is the question. I think we have to see the DSA and see if it is involving a subclavian, if it is involving otherwise, put multiple overlapping.
Subclavian is paired, sir.
Start with some covered stents below, then put multiple bare stents above.
Subclavian is paired, and the false lumen, which is thrombosed, is there in the posterior aspect of the brachiocephalic as well. But the dissection starts because at the origin of the common carotid on the right, we are not seeing it properly.
Second last, huh?
So DSA is must. Yeah. So DSA was not done yet?
No, not done yet.
I think do a DSA and then take a call.
Yeah.
Because.
Yeah, I think you're right. There's indirect evidence that it could be hyperperfusion.
It is.
But it's still indirect evidence rather than direct evidence. So if you're doing some major intervention like a stent or a bypass.
But you can also see it's direct evidence because can you see the contrast difference between the two common carotids?
Fair enough. But you have to confirm that before you do intervention by doing a catheter DSA and look at the flow dynamics. That's probably what is before you do that.
Will nobody recommend endovascular arch repair or the endovascular treatment for the dissection in 2 steps?
But how are you going to change the
no,
dynamics?
as a part, like.
No. What are we doing? Why are we doing all this? Because of hypoperfusion of the right side of the brain. By doing anything for the arch, are you going to change anything?
No, arch plus that.
That is where up to where do you go? That's why you have
Last
to know
2 minutes.
What level to, if you want to do a graft or say a bypass, at what level do you
Till the brachiocephalic, I was planning till the brachiocephalic we'll put a stent graft and from there see what it is and then put a bare stents till we can extend to the ICA.
When you put a stent, covered or uncovered, in a dissection, remember that you have to come from normal to normal. You have to know where is the upper limit. If you don't know the upper limit, by doing anything below is not going to help. So that is the primary. So you will have to do an angio, check. If you need to do a IVUS if at all, and then take a call.
Okay, sir.
I think it's a little too, kind of premature. We are working on it. So many things we are just going by it. And as said and done, good evaluation of the CT? Sit down and discuss in the multidisciplinary
This was
team?
just on a day before she came
Exactly.
to me elsewhere. So
Yeah.
all this analysis was on a CD which she got from outside. And I didn't want to
And I
repeat it
think-
because it was just done the previous day.
So I think a DSA would be a definite flow dynamics. You have to see cross circulation and then decide. And landing zone has to be very well decided. You have to do the arch, you'll have to do the carotid. Otherwise this perfusion will not help.
Yes. Thank you.
Thank you so much, Rupa ma'am. Thank you, Virendra sir. I request Dr. Virendra sir, Dr. Rupa ma'am, and the panelists to kindly join on the stage for a group picture. A big round of applause for our speaker and the chairpersons for this session. We'll have a short 10-minute break, and then the partition will be taken off, and this will be the lunch symposium. The lunch will only be served in the hall for the people who are sitting in the hall. So meanwhile, you can go for the treasure hunt to the ISVIR industry area and be back in time for the lunch symposium. Thank you.
Can I please welcome on stage Dr. Sharad Kumar sir. Sir is a consultant neuroendovascular radiologist from Manipal Hospitals, Bangalore. Dr. Dharav Kiradia, sir is a neurovascular intervention radiologist from Wockhardt Hospitals, Bombay. And Dr. Jenny Gandhi ma'am, who is the intervention radiologist at Shalby Hospital, Surat.
Second session of the second half, the carotid and vertebral stenosis. We have lined up with interesting cases, talks by the experienced speakers here. So the first talk will be by Dr. Manisha Joshi. She is a senior consultant from Rajgiri Hospitals, Kochi, and she will be talking on carotid artery stenting in elective and acute setting, case and hardware selection for optimizing the outcomes. Dr. Manisha, you can start. We will take all the questions at the end, if the time permits, and we'll go ahead.
Good afternoon, everyone. So I was worried about the postprandial nature of the session, but I hope the music therapy has worked well, and I hope that you can take home some message from the presentation. Although it is one of the most basic topic, that how to do the simple carotid artery stenting, along with that some complex cases or some complex scenarios. So I have nothing to disclose because I will be discussing a lot of hardware, but some of the hardware might be missing from this because there are a lot of hardware in the carotid stenting nowadays compared to what we saw like 5 or 10 years back. Now I think almost 50% increase in the number of hardwares. So I have nothing to disclose on that. It is just a matter of the chance that which hardware has been included or which is not in this. So one of the good news in the field, the people who love carotid artery stenting, that there is a new turn in the carotid artery stenting versus surgical debate, that till now we did not have any concrete evidence or concrete study which is showing the clear advantage of the carotid artery stenting over the endectomy. Most of the studies were showing either it is equivalent or maybe carotid artery stenting having a little bit downside. But the recent trial, the CREST-2 trial, has shown that there is a more scope for the carotid artery stenting. It was a trial which was done with the 2 parallel randomized trials on the asymptomatic carotid artery stenosis, which is more than 70%. And in one of the trial, the carotid artery stenting with the intensive medical management versus intensive medical management alone was compared. And in the other part of the study, in the other trial, the endectomy versus the IMT was compared along with the IMT versus the IMT. So primary endpoint was a stroke or the death in the periprocessal period or in the 4-year follow-up. So this CREST-2 trial was a 2 parallel randomized trial, as I told you. In this, sorry, this is a duplicate. So the result showed that the IMT alone had a 6% risk of the stroke over this time period, and the IMT was, with carotid stenting had a 2.8% risk of the stroke. And the another trial where the endectomy was compared, it was result was 5.3% versus 3.7%. So clinical implication of this trial is that in the first trial, the stenting trial, it showed a significant benefit in the asymptomatic patients, but in the endectomy trial, it did not show any statistical significant benefit. So it is something historical which has come recently, and it is important in this context when we are discussing. So this is one of the meta-analysis of the previous all trials, because there is always a debate on that, on how much stent, how much percentage of stenosis we should be doing the stenting, and that is something we have to be careful about. So this meta-analysis showed that in the severe stenosis, definitely there is a strong indication and the strong evidence. In the moderate stenosis, there is a strong and strong to moderate evidence we have, but in the stenosis which is less than 50%, there is no good evidence to support the stenting or revascularization basically. So a few salient point regarding the procedure for the carotid stenting, which has to be always kept in the mind, because the result as well as the advantage over the surgery will depend upon all these points. If we follow the proper protocol, we will have a good result. If we don't follow protocol, of course the results are not going to be as good. So patient selection has to be good, informed consent has to be always taken like any other procedure, appropriate hardware selection, timing of the stenting, acute versus interval has to be decided well, risk factor assessment of the patient has to be done well, and intra and peri-procedural patient management has to be very, very important, because that is one of the decisive factor for the outcome of the patients. Antiplatelet management of course is important, so optimal antiplatelet management and check for the resistance if possible is an important part of the management. So carotid stenosis can have a different etiology. It can be atherosclerotic, it can be dissective, it can be vasculitic or FMD, or it can be a post-radius. So atherosclerotic is most common, as we all know. Dissection is the second most common, and other etiologies are also we encountered in the clinical practice day to day. So according to different studies, there can be a different percentage of the risk of the stroke in the carotid stenosis, but some of the data shows approximately like 26% risk in the stenosis over 70% over the next periods of the 2 years. And there are certain recommendations that which patient should undergo or should not undergo, but the main point of the recommendation, I am not going into details, but the main point is that stenosis which is symptomatic more than 50%, or the stenosis which is symptomatic or asymptomatic more than 70% are the candidate for the stenting if carefully selected, and if the risk of the procedure can be kept less than 6%. So these are the few of the contraindications and indication mentioned in the earlier articles regarding the carotid stenosis, but these I think doesn't stand in the current scenario, because we have improvement in the hardware, we have an improvement in the result, and this indicates basically the cases which are not suitable for the surgery, they are mainly recommended for the carotid stenosis, not otherwise. But in the current scenario, since we have a good evidence, almost every case can be a candidate for the stenting. But yeah, there are certain points which you have to keep in the mind, particularly the patient who has a contrast contraindication, we have to be careful about the stenting. Patient who has a subacute cerebral, in fact, we should wait and do an interval stenting. And patient who has a stenosis which cannot be safely reached or safely crossed, we should definitely avoid the carotid stenting. So the contraindications or the indications were there earlier, those I think is now more of the conditions which favor the carotid stenting over the endectomy. So symptomatic severe stenosis which can be difficult to access surgically, or symptomatic severe stenosis where the significant medical disease is there and the surgical is contraindication, those are the cases where the stenting gives a upper edge compared to the endectomy. And significant tandem lesions, radiation-induced carotid stenosis, and restenosis of after the endectomy, refusal for the endectomy by the patient, and stenosis secondary to arterial dissection or secondary to vasculitic conditions, or severe stenosis with the contralateral occlusive arteries, arterial disease. All these are the contraindications usually for the surgery, and there we have an advantage in the stenting, where the stenting usually can be done safely. So coming to the hardware part, the hardware usually it's a common hardware, but except for the stenting, stent and the digital protection device, most of the hardware is common to most of the procedures. So guide sheath, micro guide wire, additional diagnostic or myocatheter can be required in some cases, embolic protection devices, balloon and stent. I am not going too much detail in each and every hardware, but the guide sheath usually is a long guide sheath, 5 or 6F depending upon the compatibility of the stent, and or a guide wire of 8, 5, 8, 6 or 7 French depending upon the compatibility of the stent. Usually usually more than 65, commonly 80 centimeter is a preferred guide sheath in these cases. RHB may be better compared to the hemostatic valve, because hemostatic valve in the many of the sheath can be too tight to cause the damage to the hardware. And microguide wire, routine microguide wire can be used if we want to do exchange maneuver compulsory, then 300 centimeter microguide wire is important. Otherwise, if it is not very severe stenosis, if we can cross without any guide catheter or the any myocatheter, in that condition 200 centimeter wire is enough, especially because we have a monorail system in these cases. Wire with the dock wire option can be important, like run through wire, which is the coronary wire, Texas wire, they have a dock wire option. They can be more helpful to avoid any much exchange maneuver or to any exchange maneuver later on if required. Rarely in the difficult scenario, we can use wires which we use for the peripheral vascular disease, like a command wire, V14, Win18, but has to be used very carefully because this is a very delicate disease. Angled or diagnostic catheters can be required in some cases where it is difficult to cross the wire directly across the stenosis, and myocatheter can help in confirming the interluminal position, especially in the cases where there is a near complete or complete occlusion distally. Embolic protection devices are something specific for the carotid stenting compared to any other procedure. So I'll go in a little bit more in detail in these cases. So depending upon the mechanism of action, there can be three kind of devices. One is filter devices, second is the flow reversal devices, and third is the balloon occlusive devices. And depending upon the position, they can be divided into distal or proximal protection devices. Distal protection devices can be filters or the occlusive devices or balloon, and proximal devices can be aspiration devices or a flow reversal devices. So this is the schematic diagram showing this, that this is a distal balloon. So what is done in these devices, basically the distal balloon is inflated, and the procedure is done with the plasty as well as the stenting, and in that time whatever debris has detached, they will collect in this area. So before deflating the balloon, all the debris are aspirated with the aspiration catheter, and once everything is aspirated and flushed out, then the balloon is deflated, and that gives us a less chance of having anything going up. Because this balloon is occlusive, it can cause a more stroke risk. The filter devices were developed. These filter devices, they have some sieve kind of mechanism where the blood can flow through the filter, and the complete flow occlusion does not occur, and whatever debris has broken from the plaque, that can go and captured in the filter. Although very tiny debris less than 100 micron cannot be captured, but the major debris can be captured. And this is the proximal protection devices, where the proximal balloon is inflated in the common carotid artery and in the external carotid artery, so complete flow arrest can happen, and the procedure can be done through the lumen without having any antegrade flow. And before deflating the balloon and after doing the procedure, the aspiration is done to avoid any distal embolization. So these are the advantages and disadvantages of each devices. I am not going into detail of this, but it is important to understand where to use which device particularly. So important thing to know is that when we are using the filter, we can allow the tiny particles to go up, but we are not occluding the flow. But when we use a distal or proximal balloon, in that condition we are occluding the flow, and the chance of stroke can be higher. So we have to be careful that there should be a good collateral flow, and there should be a good flow to maintain the circulation higher up, and the timing should be kept very minimal. So that is important to understand. So this is one of the example of the proximal protection device. This is a MoMA device, not available in the India as per my knowledge, and never has been, but this is the one of the historical device where the proximal balloon is there and the distal balloon is there in the ECA, and the procedure is done through the lumen, remaining lumen. These are usually bulkier devices because they have to have a balloon as well as the internal lumen. Flow reversal devices, again one of the flow reversal devices which we have known is the one from the Gore, that is called as Parody anti-embolic system. And this is again has a similar to the other device which I showed you, which has a balloon in the EC and the CCA, but outside there is a flow reversal. So the femoral arterial flow is diverted to the femoral vein. There is an additional femoral sheath, and that blood is filtered in this channel, and then it is pushed into the venous system directly, so that there is no loss of the blood, and because of the flow reversal, the debris will come out directly and they will not collect in this area. But again, the stroke risk can be higher in these cases. Filter devices, as I told you, they are usually they have a sieve kind of mechanism, usually nitinol mesh. They can have a single length wire or exchange length wire depending upon which device it is. And these are the example like a spider, filter wire. There are multiple examples, and new devices are coming in the market. In the distal occlusive device, as I told you earlier, it is a distal balloon. It can be a different sizes. I have not seen and not in use as per from the time I have been working, and I think it has not been available in the India earlier as well. So coming to the balloons, balloons are simple balloons, but they are similar to more like coronary balloon than the peripheral balloons. They are monorail system, and pre-plasty is almost always done. Post-plasty can be also required in some of the cases, and aggressive post-plasty is usually avoided in the carotid stenting cases. So stent again can be a different stent depending upon the stent designs. This is also a monorail system, usually O14 system. They can be balloon expandable, self-expandable. They can be laser cut or braided, and usually they are made of needle. Sometimes they are made of cobalt chromium or some other alloy as well. They can be tapered versus non-tapered. They can be open cell versus closed cell. They can be bare metal or the dual layered. So I'm not going again in the complete details of this because we have a lack of time in this, but the important point is that open cell stent has a more conformability. They are more easier to deploy in the where there is a more tortuous anatomy versus the closed cell stent. They are relatively stiffer, but they give us an advantage of having a more protection from the distal emboli, which can go in the periprocessor period. So these are the two important difference to understand, but there are a lot of other differences which can be important to know. The first self-expandable stent was a carotid wall stent. Earlier, the balloon expandable stent were the one which was used initially for these procedures, but they were not good enough to hold the strain which is there in the necks, and they were not very protective. They did not have any much conformability. So they are no longer in use commonly unless there is any difficulty in using other stent. So this is the design of the closed versus open cell. Open cell does not connect at the each cell, and the closed cell has a connection at the each cell, and there is no open cells in this. There are some hybrid stents also, again not in the practice and not in the India as per my knowledge, but hybrid closed and open cell stents are also made. So these are some of the examples of the stent of the open cell and the laser cut stents. And this is the C-guard, which has a special property that is a dual layer stent. And being a dual layer, it is claimed that the distal emboli in the periprocessor period or post-processor period can be avoided, and it can give a more benefit, especially in the cases where there is a pseudoaneurysm kind of thing. It can give a better flow diversion kind of effect as well, and it can give a more vessel wall protection from the vulnerable plaque as well as a pseudoaneurysm. So this is the wall stent I think almost all of us has used. So stent has to be chosen based on the vessel tortuosity, based on the IC and CC diameter mismatch, based on the calcified lesion, based on the vulnerability of plaque, and based on the if there is any pseudoaneurysm or not. Depending upon that, we can decide that which stent should be used in which case. Of course, we should never forget antiplatelets. We should always use RTA line because there is a risk of the asystole during the case because of the plasty in the region of the carotid body. Temporary pacing can be used especially in the cases where there is high cardiac risk. So temporary pacing is helpful in those cases, and GA versus sedation again both can be used, but depends upon the choice of the operator. So I'll skip have a cases, but I'll skip in the interest of the time. But I'll just show you one thing that I have discussed till now, the strategy on the simple carotid stenting which is used in the proximal carotid plaque where there is cervical IC stenosis. But what about the stenosis in the carotid which is above this? So in the area where there is covered in the bone like petrous or the cavernous area, in that area the commonly, if we have to do the stent, the common choice is usually a balloon mounted stent. We don't have a dedicated coronary balloon mounted stent, so usually a coronary stent are used. In the area where there is supraclavicular region, again the balloon mounted stent can be used, but because there is a more risk of a rupture, subacute hemorrhage, and because of dural link, we have a more chance of perforation. So very commonly we used a laser cut stent also. So this is one of the case where there was a stenosis in the distal ICA mainly, and there was some stenosis in the cavernous also. So both area were stented, the distal one with the laser cut stent and the proximal one with the balloon mounted stent over here. So I'm not going into the detail of the further because I think we have lack of the time.
Time is up.
Is it allowed to show one case of the acute as well? Okay, so since I got a permission, I'll just show one acute case as well. So this is a 36-year female, postpartum few months, sudden onset left hemiparesis and dysarthria, and she was found to have a dissection in the cervical carotid artery over here, and she had some watershed infarct. The weakness was out of proportion to the infarcts which you are seeing, but still we were not sure that whether how much of the infarct are contributing to the weakness and the symptoms she had. And there was not much collateral from the posterior circulation, not much collateral from the left other circulation as well, and from the left side, and there was a dissection over here. So initially we thought of keeping conservative, but patient was showing a clinical worsening over time, so we took the patient for the procedure, and we did a stent. Here this curve was difficult to navigate, and the dissection was difficult to navigate even with myocatheter. So we navigated softly, gently with the myocatheter, and instead of using the carotid stent in this segment, we planned of stenting using some softer stent. So we used a Leo stent, that was a braided stent. So we used that at time, and we opened the stent. These stent, they have a less radial force, but this stent had initially did not open in the mid segment. Then we did some plasty over here. This is the balloon plasty. After balloon plasty, the stent had opened well. There was an antegrade flow, and over the next 1 or 2 days, the patient recovered completely. And this is the CT angio in 5-month follow-up, where there was again some narrowing of the stent over here, and there was a small pseudoaneurysm also from the starting over here, but that is remaining stable. The lumen of the stent is remaining stable, and now she is almost 3 or 4 year follow-up. Patient is clinically stable, and the stent is still open. So I'll finish with this. Thank you.
Thank you, Manisha. Thank you. So we'll take the questions if there are any in the end. So we'll call upon the second speaker, Dr. Gaurav Goyal sir, who is a Director of Neurointervention, Medanta Medicity. He will be speaking on carotid stenting in hostile anatomy, especially on the techniques for the difficult arch and alternative accesses. Very important topic. Over to you, sir.
So thank you, Sharath, and thank you ISVR team for having me here. So it's not specially for difficult arch, it's only for difficult arch. So I've been given a very selective topic where we are going to talk about the hostile anatomy of the arch and how we go up. So what's in a hostile arch? Basically where you are not able to access. So it could be a type 2 or 3 arch, unfolded arch, bovine arch, or basically an osteal stenosis or heavily calcified arch. So everything may come up in your way as you are trying to do your stenting procedure. So there are many ways people describe what is type 2, type 1, type 3. So one of them is the diameter of the CCA and look at the origin of the innominate artery. So if the innominate artery is more than twice the diameter of CCA below the upper margin of the arch, it's called type 3. Slightly complicated for me. I do not follow this classification. We try to follow the simpler one where you draw a line at the upper arch, you draw a line at the inner curvature, and if the innominate artery is arising at the level between or below, defines your type 1, type 2, type 3. So in my personal opinion, I think this makes more sense. So before you start doing carotid stenting, I see mostly seasoned operators here, but people who are starting their practice, it's very important to spend 5 minutes with the imaging, look at the arch, just do not focus on the bifurcation, brain anatomy. Look at the arch, how are we going to go up? Is it a bovine arch? Is it calcification? Are we comfortable with all the hardwares which we have? And it's going to help you during the case when you deal with the hostile arch. So because most of the complications which arises is because we are not properly prepared for it. We have a poor coaxial system, we can cause dissections, we can cause embolism, and if we are stuck for a long period of time, I think that's the time where we have to look for an alternate access, like we can go by transradial or brachial, which we practically don't do anymore, or maybe as a last resort a direct carotid puncture. So we're going to talk about a little about everything in this. So Manisha, I think, gave a very good overview of all the hardwares, but starting from below, you need to have a good sheath. So our preference is having a short 8 French, 9 French sheath. So if you need to exchange your guiding catheters, it's easier. So we don't like to go bare sheath when we are doing the carotid stenting. You can choose any of your diagnostic catheters. For us, Picard is main thing. My colleague uses an H1 a lot. So these are the 2 workhorses which we use in our department. The backup plan for such difficult curves has to be a SIM catheter. So anything 1, 2, and 3 depending on your personal preference. I prefer 2 more than anything. And 035, 038 guide wires, and of course an Amplat stiff wire. I cannot say that without this you will not be able to do a hostile arch easily. Depending on what type of sheath you are using, your procedure may become successful or unsuccessful. So the neuro sheaths which we use these days, like Neuron Max, Ballast, and Infinity, they are very good, especially when you are doing on the left side. When you need more stability, if you are ending up very proximal into the common carotid artery, the stiffer shuttle sheaths like Fubuki or Cook may be helpful, but their stiffness may become your enemy if you are trying to take them into the difficult angulated bovine left-sided arch. So depending on the anatomy, you may be required to choose a proper guiding sheath. Microwires, of course, you need to cross the lesion, give you supports, and various types of wires are available. As I said, transradial is mostly, I am not the radial first guy, there are a lot of radial first people, but it's a shorter path, especially in a bovine in type 3, it's worth considering. And there are challenges of radial also, that hardware shortage, artery size may not be adequate. And direct carotid puncture is also becoming popular, though I think it should be used in an extreme situation. And of course endarterectomy is always there, so don't be hell-bent on doing stenting only, no matter what. So let's start with a few of the techniques, and I am just drawing it from my own experience, and feel free to share your experience in the end. So this is our basic thing, the level 1 I say, where you use, and I'm saying Fubuki, but you can use anything. So Fubuki, Picard, 035 or 038 wire in CCA, and you take all your systems up. And I think everybody who's doing carotid stenting knows this as a basic procedure, sorry. So this is like basic, which we do in and out, to place a wire, place a catheter, and glide your sheath over it. Then go ahead and do whatever you like with filter, without filter, stent, and so on. So moving on, if that doesn't work, same combination, but you can take your wire into the ECA. And I think when we are trying to teach our fellows, I think this is probably the safest way to do when your wire doesn't jump in. So we call it the ECA technique. So you can do your road maps, park your wire, if required, park your catheter also to the external carotid artery, diagnostic catheter, and then gently bring your sheath, whatever sheath you want to use. So you are in a complete control. Remember, these patients are under local anesthesia, so they will be moving. They may cough at the wrong moment, so you may not accidentally disrupt the plug when you are doing. You can use it with 038 wire, multiple combinations, but basically parking your wire into the external carotid artery for a safe access. If that doesn't work, we have to do the M-Platz wire exchange. So that's where I think ballast, SIM2 and this M-Platz wire exchange combination works very well. So typical bovine arch, you access it with a SIM2, simple thing. But once you are there into the CCA, you put this stiff M-Platz wire, and over this you can bring your ballast sheath. And for the left side, I think Neuron Max Ballast or Infinity, anything, they slide very, very well to do this. If that doesn't work, what to do? Just think it in your head. Okay, so you are doing this left ICA, tight stenosis. This is a SIM2 035 wire. It's in the external carotid artery, and we are trying to take the SIM2 into the external carotid, but the arch is slightly not in our favor, so the SIM2 is not climbing up. So we tried putting an M-Platz also at some point. Yeah, so that's the M-Platz. SIM38 failed. M-Platz caused a lot of straightening, but again it also didn't support. So when we were trying to put the M-Platz and taking out the SIM2, everything was just falling into the arch of filter. So which is a very common situation. These difficult arches, you end up doing this. So for this, the level 4 is you shorten the length of ballast to 80. So you don't need to do the exchange maneuver. So now you have an extra SIM which is there with you. So all you need to do is keep the SIM there, keep your wire into the ECA, and since you have now 20 centimeter extra of SIM2, you don't need to exchange. So it becomes an easier process, and you are able to take your catheters easily. So this is, and you can use a 035, 038 or M-Platz depending on the level of stiffness which is required and the catheter which is accepting it. So I'm just fast forwarding it. So this is again very common methodology which we use in our own practice. This is the following, we do an angioplasty and we put a stent, of course. So this is another case, tight curves, difficult access, and it's bad throughout. It's an unfolded arch, so you do not have a good control all the way down to the iliacs. There is tortuosity, and so we use the same combination. And here, if you will notice, even with the 90 centimeter of sheath, we are hardly at the foot end of the common carotid artery. So So there are choices now, you can abort from here or you can try from here. So this particular case, we put a filter, we could have avoided filter, and when we were trying to bring the stent won't track because it's a closed cell stent and it is requiring a lot of force there. So sometimes a change of stent works. So here we, I think wall stent was used, and that was able to track better than the exact in that particular situation, and that saved the day. So be flexible about the choice of stent. Sometimes you may have to choose from open to closed and closed to open in the same way, and eventually we were able to do the stenting from far off while in a slightly unstable position. So level 5, if that also doesn't work, you can take up same thing, ballast, sim and implants, but now we are also taking an intermediate catheter like a Cat 5, Navy and Polaris or any other which I am missing on the list. So that's going to give you a triaxial system and an extra support. So again, I designed it for the students that, sim, not necessarily you need to form it in the left subclavian. You can form it in the right side, left ICA, iliacs, at any place. So depending on which side is the stenosis, the other side you can make your sim catheters. And if you do not know how to make a sim catheter, I think it's time to change the profession. So anyway, so we tried taking it over a Picard 3538. We couldn't. So we thought we will use our 038, SIM2 and ballast for an extra support. That sort of didn't work. So we have a ballast sitting here in the common carotid origin and 038 wire into the ECA. And as we were trying to Cat 5, bring the Cat 5 up so we can get more support, everything just came back into the arch here. So failed with this. So the next step is of course to put a stiffer implants wire. So that's what we did, a stiffer implants, Cat 5 and a ballast. So now you have a triaxial system, and that really helped to take the systems up. And I think with this triaxial system, most of the times you are successful. Here we were skeptical because again we were very low down into the common carotid artery on a difficult left side. So what we sometimes do, that we track a coronary stent first, and with a plasty and stent we just leave the coronary stent there. So at least we have opened up the artery, put a stent there, and then if we can track a carotid stent, we put a carotid stent. If we are not able to, we leave it like this. So there are few occasional cases which we have done like this. This is one of them, and that's another sister case. 84-year-old gentleman, tight stenosis. Where is the timer? I can't see the timer. Anyway, so we did a pre-stenting angioplasty. We couldn't track the stent because of the sharp angulation. So we tried numerous maneuvers to bring the stent up, implants, Cat 5, everything failed. Eventually we just left a coronary stent there. So just a thought in the mind that if you are not able to track a carotid stent, sometimes a coronary stent can be a life savior for you. Level 6, now we are moving away from ballast. You can add a balloon guide catheter. So you can use balloon guide, an intermediate, SIM2 and implant stiff wire. So the balloon guide catheter, what's going to do, is going to give you a lot of support as you are trying to push up. So the main issue is the kickback of these guiding catheters. So with these balloon guide catheters, you can inflate them wherever you are at the ostium level, and that's going to give you a lot of support as you climb up. So I think this, by and large, if it's going to make it very expensive, but it works. Rather than having a failed procedure on your hand, it gives you an extra option. Plus, when you're using a balloon guide, you can also make it a triple protection. So you have a balloon guide as a proximal filter, so something like a MoMA device, which Manisha was trying to show it to you. So, and you can use a mesh-based stent as a second filter and a distal protection as a triple filter. So it's a triple protection in cases of free-floating clot. That's our preferred strategy these days. Okay, that's where the timer is.
Last 2 minutes.
So we did eventually the stent. So this is sort of the flow chart in my head. Picard 35, 38 fails, use SIM2, Teremo, exchange with implants, exchange SIM for a ballast or Fubuki. Intermittently, you can also think of using a 80 and a SIM2 so that you don't need to exchange with the implants. nothing works. I think balloon guide, Cat5 and MPLATS assembly usually works. There are longer SIM2 catheters available. Somehow it's not available with me. Whatever is available is super expensive, 30-40K catheter, which I think is very unreasonable. There are newer catheters from Medtronic, wrist catheter, mainly for radial, but we can still use for femoral. Sometimes we take the wire into the ICA. I have a not so good example to show, but we do not record everything. But in extreme situation, you can take your wire through the plaque and then use that as support, because that may be a straighter access. So this is one of those cases where we went into the ICA to put a stent. And we can also use buddy wires, 2 wires to climb up. So this is an ostial stenosis, multiple stenosis in the patient carotid. So we go up, place a stent, but in the end, when we had to take the Infinity all the way up, we placed a Traxxas and a 035 wire. So 2 wires, buddy wire techniques also can be used to climb up and then deploy the stent. Coming to the last bit of radial, bovine arch or type 3 is the most preferred way. It's easy to do and very similar to femoral, except that you don't use a short sheath here. You have to do a bare back. Do dilate well before you start doing this. Come through the radial, hook with a SIM2, position it in the same ECA technique that you can. Okay. So with
Time is up.
Last 30 seconds. Promise. So with SIM2, you can go up, track your sheath up, and it works. And so ECA first technique, and the CCA is again the same thing, put an MPLATS and you can go up. One last thing which we didn't show from the femoral, I can show it. You can use a balloon also. You can take a balloon up, inflate, and then pull all your system up. So that also works if nothing works. So if you have all this, and direct carotid, I think we have done only in stroke. I don't like to do stenting by direct carotid. I think it's too extreme to do that. But again, it's there on the menu. In last 20 years, I can say I only have 2 cases where we have failed using all this. So over 500, 600 cases, extreme tortuosity, you need to give up and send for endarterectomy. Okay, so we skip all this, and then let me just invite you to nice live meeting next September, this September actually. So 24 to 27, so do join us. Thank you so much.
Thank you, sir. It was a nice demonstration of all the possible techniques from the femoral axis. Thank you so much. So anyway, we are taking up all the questions at the end, so we will continue with the next speaker. I invite Professor Dr. Shailesh B. Gaikwad, sir, for his next talk, the very important one, the carotid artery complications, how to prevent and how to manage them. Over to you, sir.
So the previous 2 speakers have spoken very well, and they have covered the topic quite extensively. So my topic is, this is just an overview. I'll introduce indications for carotid stenting has been already covered, techniques have been already covered. I'll focus more on complication. So stroke, you know that this is the 3rd leading cause of death, but the first cause of morbidity. So you have to prevent the stroke by any chance. Commonest causes has been already listed here. So natural history, NACET trial, yes, 70 to 90%, 26% risk of ipsilateral stroke, and 28% risk of any stroke at 2 years. And in carotid stenosis, less than 75%, the rate of stroke is only 1.3% per year. But if it is more than 75%, then the stroke rate goes up to 10.5% every year. So now, what is the management? I think the management strategy revolves largely around 3 main parts. The first line is always a medical management, followed by a CA, and then carotid artery stenting. Of course, we should be thankful for the CREST-2 trial that this have shown that carotid stenting is equally now safer as compared to the CA. So there has to be a clear distinction between symptomatic and asymptomatic carotid artery stenosis, because that is very, very critical. Extrapolations are on the natural history. These are based on precise definition of symptomatic, asymptomatic disease. So what the typical TIA symptoms will come around? It will be unilateral weakness of face, arm, leg, or there might be unilateral altered sensation, dysphagia, monocular blindness, or heminopia. And what is asymptomatic? Asymptomatic means that the patient is having a critical stenosis, but has not had any focal neurological deficit on the ipsilateral side. And the period is very important within the next 6 months, right? So that's very important to know what is asymptomatic carotid artery stenosis. So management, first is medical management. Antiplatelet, we know the choice is of course very standardized now. We know we have to manage the dyslipidemia also, the other risk factor management like hypertension. And most important is the lifestyle modifications. So lifestyle modifications means the sedentary life has to be taken care of. We have to do more of physical exercises, the gymming, running, whatever. Second thing is the cessation of this smoking, because smoking is a very important risk factor, and that helps a lot because it prevents the stroke. Even if you are potentially treating the patient with stenting, you need to tell them that you have to stop the smoking, otherwise the risk of stroke will always be there, even if you do a stenting in the patient. So complications can be divided into two groups. One, peri-procedural, that is happening on the day of the intervention to the next 30 days, but there can be delayed complications as well beyond 30 days. So prevention is largely on the proper selection of the patient. Those who are fond of using embolic protection device, they can use protection device. Technique is very important, use of proper pharmacology and hemodynamic control. This goes a long way in preventing the stroke or the complications. So mechanism of complication, you know very well, that can be embolization of the plaque rupture, cerebral micro or macroemboli can happen. There can be hemodynamic instability because as you are inflating the balloon in the carotid sinus region, putting the stent, there is carotid sinus stimulation that results in the bradycardia or hypotension. The most dreaded complication in my mind is the hyperperfusion bleed, and it's very, very unpredictable. It will happen largely because of the impaired autoregulation post-procedure, right? So if the patient is having a chronic stenosis, high grade, very, very tight, and you are intervening in that, and if there is sudden gush of blood in a blood-brain barrier which has been already disrupted, there a chance of hyperperfusion bleed can happen. The complication, access device related, has been already talked about. Then pharmacology related, like if the patient is a non-responder to antiplatelet, whether single, double, or even both, I think that is a more important complication and can be prevented if you do a antiplatelet, I think, testing before the procedure is done. Or the patient may be a non-responder, may not be a, what we say, resistant to treatment, but may be a non-responder. So the complications can be divided into neurologic, hemodynamic, local and vascular. So in my mind, another complication is the acute stent thrombosis and instant restenosis, which generally happens in the delayed period. If you have heard about the contrast-induced encephalopathy, how many of you have seen contrast-induced encephalopathy in your day-to-day clinical practice? So this is another very important complication, and this is still preventable, I think. So we need to be very careful about the dosage of the contrast that we use. Repeated injection in a single target artery, I think, should be avoided. So you have to minimize the use of the contrast. Radiation injury occurs rarely in stenting procedure, but other procedures like the neuro-dedicated procedures can cause a lot of radiation, and that needs to be avoided. So these are the high-risk patients for carotid angioplasty and stenting, and this has been already talked about by Dr. Manisha. So pre-procedure, this is the checklist. We have to optimize the blood pressure. The coronary artery disease needs to be evaluated if there is a history of prior angina or unstable angina, or patient has a MI in the recent past. And we have to ensure that there is no major bleed in the last 1 month. This will preclude the use of antiplatelets, so we have to avoid this. And if there is any contraindication to DAPT, I think it's better not to do a stenting and send it for a CEA. Imaging, we know very well, we image the brain parenchyma, we do a vascular imaging. In my department, we always do a CT angiogram from aortic arch right up to the circle of Willis to know the type of the aortic arch, to know whether there is a tandem lesion and whether there is a heavily calcified plaque or not. So it helps, CT angiogram does help. So antiplatelet medication, aspirin, clopidogrel, prasugrel, and any other combination that you are familiar with, you can use it, but my choice of drug is aspirin and clopid. Only when the patient is found to be sensitive, not sensitive to this drug, I switch over to the other drugs. And embolic protection devices, I think Dr. Manisha has spoken about it in very detail, I think, so I'll just try to skip in the interest of time. Okay, so one of the complications is very, very common, I think, carotid spasm. And that generally happens because of the wire manipulation, or even the cone of the stent can hit the intima and cause vasospasm. The other cause is the putting a protection device high up in the carotid area close to the base of the skull. It keeps hitting the intima and causes vasospasm. But this is a very reversible phenomena. If it doesn't reverse, you can give intraarterial 100 to 400 microgram of NTG through the guiding sheath, and I think the spasm will disappear. Other thing is the bradycardia and hypotension, and that happens because of a prolonged balloon inflation. So the balloon inflation has to be very, very short, less than 20 seconds. And if bradycardia happens, I think we have to keep the anesthetist ready with the atropine load. You keep the atropine loaded into the syringe, and as soon as the brady happens, I think he can inject it through the IV line, which is already in situ. If the patient is having underlying coronary artery disease, then when the blood pressure drops or brady happens, I think it can precipitate myocardial ischemia. So we need to have a baseline investigation done for assessing the coronary artery status. Avoidance, pre-procedure hydration, you can give prophylactic atropine or glycopyrrolate in high-risk cases. Temporary pacing sometimes may be required, and balloon should be very, very minimal, shorter duration. Sometimes we can take a smaller balloon, like 3 millimeter balloon, just to create a passage for the delivery system of the stent systems. Then pre-treatment with atropine, and then significant management of the BP. If the BP, systolic blood pressure, is more than 25% below baseline, or it is below 110 millimeter of mercury, then you need to treat this patient for the with the dopamine infusion, generally in the range of 2 to 5 microgram per kg per minute, but the maximum dose should not exceed 50 microgram. So pre-dilatation versus primary stenting, I think this is another very important concept. If the delivery system can be easily crossed in the presence of a critical stenosis, I think you should not pre-dilate. What I do, I generally prefer a pre-dilatation for simple reason, because sometimes if the stent doesn't expand fully, it is very difficult to retrieve the cone of the delivery system. So in that situation, I generally pre-dilate, but I avoid post-dilatation if the residual stenosis is less than 30%. So I avoid post-stent dilatation because it is much more risky procedure than the pre-dilatation. So coming to the severe and sustained hypotension, it happens generally in 4 to 11% of the angioplasty stenting procedures, and it not usually associated with any adverse clinical events during the 30-day follow-up period. However, careful hemodynamic monitoring in the next 24 hours in the ICU setting is extremely important, and the patient generally responds well to intravenous hydration and prolonged administration of the small doses of intravenous vasopressin. The role of low-dose midodrine has been already evaluated and published in the literature, so only in resistant cases you can use this drug. Distal embolization generally happens, and it can cause TIAs, major strokes, and other things, and this is how we manage it with the medical management. Sometimes we can do a stenting, sometimes we can take a microcatheter and put TPA also. You can have, I think, TNK also. So these drugs should be always on board when you are doing any procedures without filtration. And this is the anatomy which is very hostile, and in my opinion, you should avoid putting a closed cell design in this situation. If the artery gets straightened up, I think you can then put a closed cell design. Otherwise, I think the open cell design is much better in this situation. So prevention of ischemic complication, again, technique important. Minimize the wire, catheter exchanges, keep procedure time short, avoid repeated passes. You can use embolic protection device, pre-dilate only if it's necessary, and post-dilate only if the residual stenosis is less than 30 to 40% of this stenosis. Then ischemic complication treatment, I have already highlighted how to treat that. But sometimes when it's a large vessel occlusion, you can do a thrombolysis, you can do aspiration the usual way, the mechanical thrombectomy. But if it involves a smaller artery, then you can take a microcatheter right into the artery which is occluded and give a small dose of 5 milligram of bolus, followed by slow infusion of the TPA, right? Or you can give 2B3A inhibitors. I generally prefer 2B3A inhibitors because it generally helps in a fresh or acute thrombus. So hypoperfusion bleed, I think the risk factors generally are severe stenosis with long-standing hypoperfusion. If there are poor collaterals, or there is a recent incidence of stroke which is involving a major territory, and post-procedure, if there is evidence of hypertension or there is a complaint patient is complaining of dizziness, headache, right, altered sensory, or the patient is yawning on table, that's the time when you should suspect that something grave is happening. In that situation, you should always do a DynaCT and rule out a hemorrhage. Otherwise, you can do a Doppler and look, there's a systolic peak velocity. If it is more than the baseline, I think then you are invited for the trouble, and I think it needs to be prevented. So I have seen almost 6 patients with hypoperfusion bleed in my career so far in last 25 years. And 3 of them died, and we could, I think, save 3 patients. And you have to keep the neurosurgeon on board. If the bleed happens, I think the first thing is to reverse everything, including heparin, including antiplatelet. You can give fresh frozen plasma, you can give platelet aggregates. If nothing works, then you have to ask the neurosurgeon to do a prophylactic decompressive surgery, and that can help to save the patient. So hyperperfusion bleed is a very dreaded complication in my mind, and generally happens when there is a bilateral carotid stenosis, and if you are treated that simultaneously or at a very short interval. So if you pace the stenting significantly longer, like 6 weeks to 8 weeks later, I think this complication can be avoided in presence of a bilateral stenosis. Fortunately, it happens only in 0.3% of the procedures, and risk factors have already elucidated. The patient can complain of headache and Cushing response, altered sensorium, including focal neurological deficit. Treatment, manage BP. If the BP is on the lower side, it's a saving grace, I think. You can reverse with heparin, with protamine, and everything else. And I think the next complication is vessel dissection. Fortunately, it doesn't happen that commonly. But sometimes if you are very harsh, you are using with the harder wires and the exchange maneuvers, then the dissection can happen. Sometimes it is self-limiting. But if it is flow-limiting, then you have to treat it, put another stent or extend the stenting procedure. Acute stent thrombosis has to be managed with the TPA or aspiration or anything that helps to preserve the artery. You can give intracarotid abscessimab, 0.25 milligram per kg, followed by a continuous IV infusion in the dose of 9 microgram per minute for at least 12 hours, and then repeat a Doppler or repeat a CT angiogram next day morning. So this is how we manage it. This is post-procedure management of the, and this has been published in the earlier guidelines, American Stroke, but this has become very old now. And we have recent guidelines which have shown that stenting is equally safer as compared to the CA now. So contrast-induced encephalopathy is very rare. Only 0.1% of the cases I have seen that. It's very, very transient and generally reversible. Patient may become agitated, but the finding that you should look for on imaging is the post-procedure CT scan, non-contrast. You will see gyral enhancement and effacement of the sulci. Sometimes midline shift can happen. But generally, if you treat them with steroid, I think the patient will reverse in next 24 to 48 hours. Very, very rarely, the patient may develop large infarct because of the breach in the blood-brain barrier. Instant restenosis, again, very, very less. I think it's just about 6% of the patient may develop restenosis. Within the first 2 years, you get more incidence of restenosis, but that is largely because of the neointimal hypoplasia. And this subsides if you give a low dose steroid a short period. Yeah. I'm just ending. So I will like to conclude by saying that there is increasing evidence in support of carotid angioplasty and stenting, reduced complication with proper imaging assessment and planning, and outcome depends upon operator experience and selection of the cases. Unprotected stenting can be done in Indian scenario, and the paper is now going to be published very soon. I'll share the link. But we do not have a proper RCT to know whether the, I think, protection device versus unprotected is going to help or not. But pharmacotherapy and risk factor control management is the key for long-term outcome of the stenting. And if feasible, I think stenting should be done whenever the patient is high risk for surgical. But of all the strategy, I want to end my talk by saying that knowing when to quit may be the best option. This is a Chinese proverb, and if you can't do it safely cross the wire, I think you give it to the vascular surgeon. And I would like to end my talk by acknowledging the role played by my mentors, Kiran Murphy, Charles Kerber, and Klaus Matthias. Thank you very much.
Thank you, sir. Excellent talk. All related complications are nicely covered. So next we have Dr. Chinmay Nagesh. He'll be speaking on indication technique hardware for vertebral artery stenting. Dr. Chinmay is a senior consultant, neurovascular interventional radiology, work at Apollo Hospital, Bangalore. Over to you, Chinmay.
Thank you. I'd like to thank the organizers for this invite and the hospitality shown. So today I'll be covering on vertebral artery stenting, both intra and extracranial, talking through some of the indications, the techniques, and the hardwares. So, where are you likely to encounter a reference for vertebral artery stenting? So, your main clinical scenarios, if you want to look at it, it's acute when it's a stroke or a dissection. Sometimes you can get traumas and iatrogenic after surgery. Subacute and chronic, you'll have patients who come with recurrent posterior circulation strokes, VBIs, subclavian steel sometimes, a stump syndrome, or even asymptomatic cases. Now, if we have to go about it, let's just go through the basic anatomy. So we've got 4 segments, the preforaminal up to C6, foraminal, Atlantic, extradural, and intracranial, which is also the intradural part, which also has the most branches. If you were to look at the pathologies, vascular pathologies affecting, you would look at stenosis and atherothrombosis, which is mainly V1 and V4, bony impingement, which is mainly V2 and V3, and dissections which occur mainly in V3, but also sometimes at the V1, V2 junction. Now, what is your hardware? So, if you had to look at it, access is everything, number one. So, with access, it's about the site of access, whether it's radial or femoral. If it's a right vertebral artery that you're going after and you've examined the pre-op angio, then you can go directly for a wrist access and go for access through that, sheathless of course. A guide system, you usually go for a primary guide like a Seribase or a Neuron Max, something that is supple, but if you're sticking in the subclavian, maybe a stiff, something like a shuttle will also do. You need a support catheter, particularly when you're going into the V4 and V3 segments. That will usually be a 5 French Catalyst or a Navion or a Polaris, any of these new ones. Wires wise, your standard is an 014 wire. Sometimes you can even go for a PTCA wire. Additionally, you should always have a backup of a 300 centimeter wire. Suppose you want to exchange, you need sometimes support for a buddy wire technique. If you want to station the subclavian in the guide catheter in the subclavian, you can station a 18 wire parallel to your intermediate catheter in the in the distal subclavian and brachial arteries, things like that. A microcatheter, of course, the 21 system catheter is useful to navigate, particularly when you have tortuous anatomy, and then you can exchange the wire. The core interventional hardware is, of course, embolic protection when you're working with the proximal vertebral artery. Filters are useful when you're working with the dominant or the sole vertebral artery. Balloons when you have a codominant system. Balloons and stents, you can have both dedicated neuro as well as many often on table you'll only have your coronary hardware. Okay, this is now, that was in general, with specifically to V4, what else do you need? So, of course, the delivery microcath for O21 system, a Phenom, a Track 21 or a Headway is very useful to navigate from, say, where your V2, where your guide system is parked, to go all the way into the basilar. A neuro wire is particularly important so as to not perforate and not cause any other issues. Sometimes if you have a docking wire that can be attached, say for a Traxxas wire, that is also useful. And of course, a parallel wire like I said. Now, the balloons and stent, you've got neuro and coronary. For the delivery, you've got sometimes a combined balloon and delivery catheter. It's called a NeuroSpeed PTA. It's by the Candice company. And you've got dedicated ICAD stents as well as a Chinese stent, which is the first balloon mounted drug eluting stent for specifically intracranial. Okay, so what else? It's not just stenting, you can also do something called SMA, submaximal angioplasty. So what's the advantage? The advantage is that sometimes you don't have to continuously give dual antiplatelets, you're not so dependent on it, particularly patients with large strokes or at risk for hemorrhagic transformation. Also, if you do a stenting, you're more likely to cause dissections, perforations, ruptures. Plaque emboli are also more common. branch vessel occlusion because the snowplow effect are also more common. So submaxillary angioplasty just gives you enough working space for the flow to re-establish. It does not give you a very aesthetic this one, but if you find that it is a vulnerable plaque and it is re-occluding, then you have no option but to stent. Okay, now coronary stents. Two stents that at least I use in my daily practice. You've got the Medtronic one, which is called the Onyx Frontier, and you've got the Abbott one, which are Xience Sierra. These are the two latest stents that are used. Basically, if I had to just sum it down to two things, it was Onyx is for tortuosity. When you've got a tortuous V3, V4 dolichoectatic, that time you use an Onyx Frontier. You've got a tight stenosis, you want navigability, means you use the Xience Sierra. This is the basic funda of it. You always try to size exactly, if not 0.5 mm less, so that you can always overexpand after. Dedicated intracranial stents, the two ones for ICAD are specifically Credo and Enterprise 2. Neuroform Atlas is actually an aneurysm bridging device. Wingspan has got too much of high radial force, which is why it has led to failures with the past sample trials, etc. And of course, you've got the Nova DES. Now, why do we want a drug-eluting system? The ideal thing would be a self-expanding drug-eluting stent that's yet to come into the market. But overall, if you look at the data, your rates of in-stent restenosis long-term is about 10 to 15% with bare metal stents, drops to about half, maybe about 5 to 8% with the drug-eluting stents. So my rule of thumb is, if I find that I can navigate my 5 French intermediate catheter till there, most likely my drug-eluting stent will also go till there, which means I can use something called a Trojan horse technique, where you take your intermediate support catheter into the stenosis, take the drug-eluting stent till there, and then you deliver it, and then you pull back. I mean, before you deliver it, you pull back the deploy the stent, you pull back the Navion catheter. So basically, prefer a drug-eluting stent over a bare metal stent, except when tortuosity is prohibitive. Y connectors. Now, these are small things that just help in sort of preventing too much of exchange or loss of access because you realize you've run out of length. Because we're working with coronary hardware, you've got shortage of length. So ideally, you would use this green one which comes with your Neuron Max. It's just a hub, a diaphragm hub, and you can attach that to your basic guide catheter, and then within that you can use the shorter Y connectors. You get one that is much shorter. I couldn't get the photograph of that, but you get one that is even shorter than this, and that's about maybe just 3 centimeters or something like that, versus the usual push-pull type or the standard screw type hemostatic valves. Okay, so we'll just go through maybe 4 cases. So this is an interesting case where it was a 73-year-old with recurrent posterior circulation strokes. It was non-disabling. On imaging, he had cerebellar and left PCA occipital stroke. His right vertebral artery was occluded. His left vertebral artery had a direct arch origin and with a stenosis at the V1. So you can see the bald left subclavian over here, no vertebral artery arising, and there's only an ascending cervical over here, left PCA occlusion on the baseline angiogram, and this is what it looks like. So sometimes it's about taking an oblique view. Sometimes non-subtracted images will also help delineate. You've got that calcification over there, which also helps you figure it out. So we used the same sort of angled guide catheter and took a wire like this across. And initially we were able to get the wire, but this is one of those nightmare cases where just an angiogram and it slips out. So I had to re-access everything, and then very carefully we tried to get it distally, but it refused to go because of the distal curvature. Looking back at this case, what might I have done different? So maybe I would have taken this inside a microcatheter, taken the microcatheter up, and then exchange it over a docking wire or a 300 centimeter wire so that I have some distal purchase. How would that have helped me? It would have left less of this stent overhang within the aorta, which can be an issue. In this case, luckily, it didn't cause any issue. So finally, using just this amount of purchase, we got in a stent and stented him. Patient continues to do okay. Right. So this is the final pre and post V1 standard, with an ectopic origin. Okay. What else? So sometimes you will have subclavian and V1 stenosis because of a combined plaque. You can see that this is a 75-year-old female who came with typical vertebrovascular insufficiency syndromes. She didn't have any strokes. The right vertebral artery is near occluded over there. The left vertebral artery is showing severe stenosis along with the subclavian heavily calcified plaque. Okay, so you can see over here the hairline thin stenosis of the vertebral artery. So I initially pre-dilated that with a 2 mm balloon, and then this was interesting because we took a dual access. So we took a left vertebral artery access. The patient is in the same position as for any neural case. So right femoral access and a left vertebral access, and we took in a standard catheter inside neuron max, and then got into the subclavian, then crossed the lesion with a standard 014 wire, and you can see that's a coronary guide catheter over there. And then after the pre-dilatation, enter with a filter. Now why a filter in this case, not a balloon? Because there's the other vertebral artery is occluded, so I can't afford to lose the entire vertebral circulation with a balloon, no matter how temporary. So I preferred a filter. Pre-dilated with a wire track balloon, then upgraded to a 8 mm balloon, and then finally we used a balloon mounted stent. The filter remains in place so that in case there is no flowing effect, we can always go back into the vertebral artery ostium and pre-dilate. So you can see at the end of it, we have matched it perfectly. Balloon mounted stents give you a good position accuracy. And so at the end of it, this patient continues to do well. Her BP is improved from, I think, a difference of around 20 to 30 millimeters between each arm to now it is completely normal. And the symptoms have also stopped. Now this is another case where you are more likely to come across. So this is a case of acute vertebral artery occlusion. The right appears to be a CTO, a chronic thrombotic occlusion. The left appears to be a near occlusion. And you can see this is how it works actually. So you can see that the left vertebral artery is filling slowly. There's actually a spinal artery that is reforming the right vertebral artery, and to that to the basilar artery. And then there's a near occlusive stenosis over here. And you can see the spinal artery here as well. So what did we do? You can see it's an extremely thin hypoplastic vertebrobasilar system. So we just could take a 5 French Navian in there. Next, what did we do? We basically crossed. Initially, we put in a stent reaver so that we could get an idea of what the underlying vessel was like, see whether it works like a plasty as well. Found that it was rapidly reoccluding. Didn't get much clots, maybe a minimal amount of white clots. So you can see over here the maximum diameter is around 1.8 to 1.5. So we took in a Onyx Frontier 2 into 18 and stented it over there. So you can see again, even with the 5 French Navian lying in the mid V2 vertebral artery segment, we were able to get up an Onyx Frontier. Now this may not work in all these ones. Ideally you would like to have your tip of the guide catheter somewhere at the V2 V3 junction. Okay, another case. This is a dominant vertebral artery occlusion. This gentleman had come with an acute stroke, giddiness followed by reduced sensorium, multiple posterior circulation strokes, but importantly brainstem spared. You can see the right vertebral artery is sparingly filling till the mid V2 segment. Even on delayed segments it is completely occluded, heavily calcified and occluded even in the V4 segment, and there is a very thin left vertebral artery that is supplying the basilar, which is patent. No PCOMs, which is why he was surviving solely on this left vertebral artery, this one. Now these are the baseline angiograms. This is actually quite a large vertebral artery equivalent to the internal carotid in the cervical region, and you can see the plaque is extending all the way from till the proximal basilar artery. And there's a very severe narrowing of the left vertebral artery at the junction. So you can see again, we took
last 2 minutes.
Now to get the clot out from the V3 and the V4, from the V2 and V3 segments, you can take directly a neuron max or your cerebase DA, a 90 centimeter, all the way till maybe even the proximal V3 segment, suck out all the clots using a Solumbra technique. And then you can see over here, we're getting an idea of how long the segment of the plaque is during the stent reaver placement. That's the tips of the stent reaver over there. And you remove it, we found that it was reoccluding. So now what? We have to stent. A lot of clots removed, as you can see. So basically we overlapped, it's a 6 centimeter long plaque. So we decided to overlap a Credo stent, which is a 4 into 20, which is the longest we had on table, and a Megatron coronary stent. The interesting thing about the stent is, although it's 4 mm, you can dilate it up to 6 mm. So basically we achieved overlapping stents and a good angiographic result. So basically this is the final pre and post. Patient did relatively decent considering the amount of infarcts. He did develop some post-reperfusion edema. Okay, V2 and V3, do we stent? Ideally, no. These are mobile areas, there's a lot of movement. But there are some. The Chinese, as usual, tend to go very aggressive with stenting. So they've stented there's one case report of a V2 segment atherosclerosis, which they have stented and has good long-term results. There is also one more from Adnan Qureshi, which was presented in SVIN, where they've done even due to cervical facet hypertrophy, a little bit controversial, I would say. Okay, last few slides, vertebral artery stump syndrome. Basically, it's because of incomplete proximal vertebral artery occlusion. You can revascularize if medical management fails. An antegrade approach is to go like how you would do any other CTO. A retrograde approach is to go through the collateral, reopen the ostium, and then use that to get into the this one. So you can see over here, similar kind of case. They've taken the ascending cervical, gotten in a microcatheter, widened the ostium, and then come out. Right. So my last slide, for summary, you are most likely to encounter vertebral artery stenting in an acute stroke, sometimes a vertebral basilar insufficiency. For complexity, look at tortuosity, which side is dominant, which is for right or left, you will decide on what kind of access you want, and also whether, what kind of hardware, embolic protection for proximal, exchange maneuvers, whether you can use a microcatheter to navigate, things like that. See if you can get away with a submaximal angioplasty in the acute phase, otherwise you have no option but to go for stenting. And when stenting, consider a drug-eluting stent as the first option rather than a bare metal. Antiplatelet, it's similar to carotids. For proximal, you would use just 6 months of DAPT followed by lifelong echosprin. For intracranial and V3, maybe a 1 year, this one. Thank you.
Thank you, Dr. Chinmay. That was excellent talk, beautiful images. Thank you so much.
Thank you.
Next, we have Dr. Jenny Gandhi. She is a senior consultant IR based at Surat. She will be presenting case-based discussion.
Okay. So mine is a case-based discussion regarding the extracranial carotid and vertebral disease. So the first case series I'll start with some simple one and go to a complex one. So the first is it's a shower of emboli into the left ICA territory leading to stroke, minor stroke, recovered. So angio showed there is a left ICA severe stenosis which we stented, a routine stenting like a carotid stent. Another case where there is a similar minor stroke recovered in a week time. On investigating, there is a stenosis in the left ICA, but this ICA, it is not at the bifurcation, 2.5 centimeter distal to the bifurcation. So, and this patient had a history of radiation. He was a case of CA tongue, had a radiation 10 years back. So there was a severe stenosis. So probably this was a radiation-induced stenosis. So here, point to note is when you have a good landing zone proximally, away from the stenosis, try to not to cover a bifurcation and start from origin of ICA. Here it's very important because it's a self-expanding stent, so you have to deploy from distal to proximal, so you have to make sure that it should not cover a CCA bifurcation. Another case, carotid stenosis. This patient also had he had a dyslipidemia, diabetes, hypertension, and history of stroke. Left ICA, there is a stenosis. Again, he had C hypopharynx, so had a radiation 8 years back. We were not sure whether it's atherosclerotic or radiation induced, probably radiation induced, but not sure. So treated like a normal carotid stenting and placed the stent, balloon angioplasty followed by stenting. Patient was doing extremely well. This is a CCA run, left CCA. I am showing it because this patient returned back after 1.5 years. He was coming for a follow-up, was asymptomatic. All lifestyle modification he was on, but in spite of that, after 1.5 years, he again had the symptoms in the same territory. So he went to a physician, he did a CT angiography, So in CT angiography, I don't have images. So after that, it was referred to me back again, and we did DSA. And can you see the stenosis? Again, there is a stenosis which was not there 1.5 years back in the left common carotid artery. And here it was in the mid-distal segment, which was away from the proximal landing zone of a stent. And he had a radiation history. So we did a overlapping stent, and this patient had developed right common carotid artery stenosis also over a period of 1.5 years. This was also absolutely normal 1.5 years back. So because of a radiation history, we probably correlated it with the radiation, and we treated the right CCA with a stenting at the interval of 4 weeks. So to conclude, atherosclerotic stenosis is common at carotid bifurcation due to wall shear forces. Radiation-induced stenosis can happen usually, approximate 8 to 10 years, so maybe after 5 years of stenosis, normally in the beam of radiation, and it is not typically seen at the bifurcation. It is either distal in the extracranial carotid artery or in the proximal, like a mid or distal common carotid segment. Irrespective of etiology, the treatment is same, but chances of recurrent stenosis at the same level or proximal or distal is common with the radiation, and patient requires stenting. So radiation-induced stenosis, whenever we are treating patient with radiation-induced carotid stenosis, patient requires close interval follow-up. Second, so identifying the etiology and to decide the time of treatment. A young gynecologist nearby town from Surat, very good renowned practice, had a history of headache for 3 days. So he went to salon for a massaging, like a head massage and scalp massage, developed a sudden onset hemiplegia while he was having a massage in the salon, and which recovered in 10 minutes, but he went to nearby hospital, did the MRI done, there was no infarct. CT angiography was done, which showed a complete occlusion of a left ICA. So neurologist saw the case and he gave IV thrombolysis. IR opinion was taken 8 hours from the onset. Meanwhile, patient was shifted to Surat in Apex Neuro Hospital, and a call was given for the IR. So the onset was somewhere around in the morning. I saw patient in the evening 4 p.m. At that time, he was clinically well preserved. GCS was 14/15, no deficit in any form except some cognition, cognition problem. If you ask a very complex question, he was not able to recollect it very properly. Because there was no motor or sensory deficit, there was no speech difficulty, he was doing very well, clinically, neurologically stable, so we decided to conserve and not to intervene, having a close monitoring in the ICU with antiplatelet and anticoagulant, because there was not much infarct also on MRI. But at night, that is after almost 8 hours of my examination, I got a call that patient has become aphasic, the power has reduced to 0, and patient is not following command, there was a hemi-neglect, immediately scan was done. So now there was what do you suspect? There is a possibility of MC occlusion, probably because of thromboemboli and causing major vessel occlusion. On MRI, there was an infarct, acute infarct, which was not there on a previous, the morning scan. So this was the thrombus which I could see on SWI images. So took the case for the intervention, explaining all pros and cons. This was the dissected segment, and this is the opposite right ICA run, which showed that there is no, across ACOM there was a not good flow, which was seen on a CT angiography previously. So navigated very carefully across the stenotic segment with a microcatheter and wire. Took a microcatheter run to confirm whether we are in true lumen or not, and it showed that MCA is occluded. So first did the distal mechanical thrombectomy followed by proximal stenting and fixed the dissecting segment. At the same time did the mechanical thrombectomy first, while coming back put a stent. So patient did well, though because there was a basal ganglia, in fact he took time, almost 1 month to recover, and with some deficit he's doing well now. 36-year, another patient, a similar companion case. He was a banker working, very active guy. One day suddenly he developed a transient weakness in right upper limb, lower limb and speech difficulty in 24 hours twice. First episode he recovered in 10 minutes. Second episode after 4 hours of similar complaint. But it also recovered in another 10-15 minutes. So he came back from the bank, but the headache was persistent. He visited his nearby family physician. That time he had a good power. There was mild slurring of speech. So neurology reference was given. Neurologist did describe the MRI which was done, and we can appreciate, though the images are very small, there were tiny infarct in the watershed area, inner watershed area. And MR angiography showed, high-grade stenosis in the petrous segment. So probably it was a dissection. So DSA was advised to the patient, but as patient was clinically well preserved, they got ready to admit, but didn't want any intervention or DSA at that point. So we kept patient in ICU conservatively with close monitoring on antiplatelet and anticoagulant. But he deteriorated in next 24 hours and power became 1, 2 and he became aphasic. So that time relative got agreed. By that time the IC was completely occluded from the neck. So again the same technique, navigating microcatheter wire very carefully distally across this dissecting segment, making sure that we are in the true lumen and not in the false lumen. Here you can see the effect, the contrast is going into the false lumen also. So after securing the wire and microcatheter distally, took a run from the guiding, which showed that we are across the dissecting segment but in the true lumen and not in the false lumen. Then secured it because it was a bend. I could not take a carotid stent across the bend, so first put a neuro stent and followed by a overlapping stent because the length was more. So we have done a cases where we have to keep a 3 overlapping stent across the dissecting segment of 5 to 7 centimeter. So patient, this is the end result. Eventually patient improved and did well. Because it was in hospital stroke, we could recover patient without much neurodeficit. So this is the end result. And so, yeah. Another case, 50-year male, sudden onset hemiplegia, slurred speech, power 1/5, recovered in 1 hour. So this was the MRI, which showed ACA territory infarct. In the right ACA territory, and this is the angiography which showed dissection again in the petrous segment, but there was a good flow across. So, and the patient was kept under close monitoring. There was no further progression of infarct or any neurodeficit. So we conserved patient, and eventually patient had some difficulty in walking in initial, but with physiotherapy he did well with some problem in the left leg. So, so for this cases, carotid dissection is one of the important etiology for acute stroke. Patients who clinically are well preserved with less neurological deficit, we can still monitor. It means that there is a good collaterals across ACOM, PCOM, the circulation is good, or there are good pile collaterals. So we can still manage patient with antiplatelet and anticoagulant. If the patient has a much neurological deficit or on conservative management patient worsens, then patient requires immediate intervention. With high NIS score, DSA shows
Last the level. 2 minutes.
DSA shows level of dissection. Be gentle through, navigate the dissection, get into the true lumen and choose appropriate stent. Another case, same goes with any etiology like atherosclerotic. Here, recent case, IC was occluded, but there was good collateral across ACOM. Patient had minimal neurological deficit, so we didn't chase to open this carotid and we managed patient conservatively. So case series 3, bilateral pathology, just to keep this patient had a left watershed infarct. Minimum, we did carotid stenting on the left. On investigation, right was also severely, there was a severe stenosis. So we did this stenting also, like a kissing carotid stent, but at the interval of 4 to 6 weeks and not immediately in the same setting or very early. So I would like to take opinion of a senior, like how, what is the shortest interval of bilateral carotid stenting. Similar posterior circulation. So when you have both vertebral artery stenosis, choose a dominant and patient is symptomatic, choose a dominant vertebral artery to treat with angioplasty stenting. The detail just, the previous talk, it has been covered elaborately. So bilateral common carotid artery stenosis is very common. Symptomatic should be treated first, followed by asymptomatic at the interval of 4 to 6 weeks. That's what I follow. For vertebral bilateral, always choose a dominant one and do a stenting. Multi-level pathology in same artery, like here there was a vertebral artery origin stenosis. This was the dominant one, right was the hypoplastic, and he had proximal basilar stenosis also. Relative was asked about the intervention, but they wanted some time, so we shifted patient from clopidogrel ecosprin to ecosprin brillianta. But in a 48 hours, patient developed the acute stroke in a, like you can see here in the posterior circulation in the midnight. We did, and this was the reason the basilar got occluded completely. So we went through the stenotic segment, did mechanical thrombectomy for basilar, did stenting for the basilar artery. While coming back, we did left vertebral stenting. We stented the origin also. So when there is a multi-level pathology, first treat distally, followed proximally. When the stroke is due to ICAD, MT should be followed by stenting. Always keep one balloon and stent in shelf, not only the coronary but neurostent also. Be cautious while using coronary balloon and stent because the intracranial segment doesn't have a, the 3 layers are very thinned off and chances of rupture and perforation is very common. So just to conclude that we treat human beings and not the angiographic image. So don't always chase every occlusion and every stenotic. See the hemodynamics in the brain and how it's affecting the patient's symptoms and decide accordingly. Thank you so much.
Great presentation, Dr. Jaini. So to keep in mind, there are other causes of carotid occlusion, dissection, radiation, very well covered in your cases. Thank you so much.
Thank you.
Now we have Dr. Sibasankar Dalai. He's a senior neuro and vascular intervention radiologist from Vizag. So he'll be presenting on building a carotid practice. Over to you, Sibabai.
Good afternoon. Thank you, ISPR, for the invitation. So this is a very interesting talk. So I have to talk like a politician or a guru. Gaurav met me. He said that, are you going to talk like Ramdev Baba, a guru? I said, no, maybe like a management guru. Because now we have become expert how to manage disease in the carotid and vertebral. But the big question is, how do we get those patients? So when I started IR practice, I realized that it is easier to treat a patient than to get a patient. So the talk is about all this. And why this matters? Because stroke is increasing. Identifying stroke and treating with various modality is increasing day by day with multiple trials coming. Carotid disease burden resulting in stroke is also being more and more identified with CREST-2 trial. We are in a very strong platform to do a carotid artery stenting. We don't care anymore whether there is a carotid endarterectomy fellow is there or not. We can always do stenting to everything. And with Gaurav explaining that, we can do circus to everything and we can reach anywhere and we can do a stenting. Excellent talk by all the speakers, so I'm not into the carotid talk. So what is the objectives that I have when I want to build a carotid practice? First is a good patient selection, because anyway we get less patient, we should not have complications. So right patient selection, and you should have a right technique so that your complications are least. And whatever you do, you try to present it nationally, internationally in different meetings so that your colleagues develop a respect for you that you are a good operator. Publishing those data in scientific journals will be also of great help to get patients. Creating awareness in social and otherwise all types of media is very important. And whenever possible, you can also live stream those cases to create an awareness among the public and the doctors, and you can also say that you are a very good operator, very confident, because you can do this way. Now let's come to this point 1 and 2, patient selection and technique and safety. So how do we manage? Basically a comprehensive stroke center is the right way to work. So if you're working in a stroke center where a lot of stroke patients are coming, you will also develop a carotid artery practice. It is very difficult to do carotid artery practice without you treating stroke. So very important that you should be in a stroke center. Second is you get well trained so that your results are much, much better. Third, you should have a team who are mostly working with you for years together, so they are well trained, they know what to do, where to do, and what you expect out of them. Imaging, dedicated high-end cath lab, ICU and rehabs are very important for a good outcome after carotid stenting. So again, filter, non-filter, those things has been covered, complications has been covered. Now coming to the point number 3, presenting in national and international for very, very important. When in 2006, I'm an old man, 19 years I'm practicing this. 2006 I started practicing interventional radiology in Visakhapatnam. I gave the first lecture in the hospital, in-hospital lecture. So at the end of the lecture, suddenly a cardiologist gets up and say that, Dr. Dalai, I also do carotid stenting. Why do you think that I should be referring you a patient? I said, you also do carotid stenting and I do only carotid stenting. There's a difference about it. So you should be very vocal about it, and you should, because I said that you are well trained and you have already known that what are the things all about. Now you should be very clear about your objective that yes, I will do it, and you should be very firm about it. And they start believing you because of these multiple steps I have told you. Like this is one of the very important steps where I am speaking at Orlando, USA about carotid artery stenting in difficult anatomy. Now when this image flashes in the hospital, they know that this guy has some ability to do the things well and present it well. This is with the Matthias, who has done the first stenting in the history. And again locally, see example, November we were doing the EOM stroke update. Again I just called my cardiac surgeon that you speak about endarterectomy and I will speak about stenting. Let's make a debate out of it. So it's very important that you speak locally, nationally, internationally about your work, especially in the carotid segment, because there are a lot of operators to compete with you. Next is publishing. Very, very important, because once you have more and more and more publication, definitely you will be accepted by your clinical colleagues more and more. So keep publishing challenges in carotid artery stenting or catheter-directed intraarterial heparin therapy in acute ischemic stroke and log segment carotid artery disease beyond thrombolysis window, or carotid artery stenting by non-femoral arterial approach in patients with difficult anatomy, because I have the distinction of doing direct puncture carotid artery stenting first time in India, long back, 15 years back we have done in very difficult anatomy where we directly puncture the carotid and do the stenting, but that's not enough. You must publish it, very important. And again, the next level of activity that we should be doing is awareness. Now, why I have shown this slide is because if you just look at the logos, like there are a lot of IMA. I try to cover all the Indian Medical Association chapters in all the small cities like Vijayanagaram, like any IMA meeting is there within 200 kilometer radius, I'm definitely there. 24th of January, I am going to Chhattisgarh. So it's like you have to go, you have to speak about yourself, you have to speak about the procedure, because again, I am saying that we have become an expert in doing the procedure, but we have to get the patient. So awareness is very, very important. Because you are not a real clinical fellow, people tend to forget you. So you have to keep reminding that I am doing this well. Awareness. Now coming to social media awareness, very, very important. So please, every one of you, you must have your account on LinkedIn, YouTube, Instagram, Facebook. Because we must understand that you can, at a subconscious level, you can always influence your audience and your patients and the referring doctors. So use it wisely, like for example this, whatever activities you are doing clinically and whatever possible complex clinical scenarios you have been dealing with, and try and go and reach out there. And next is the YouTube, very, very important medium. So you can create beautiful videos and speak about stroke, its prevention, the carotid artery disease, or any other disease that you are practicing. Very, very important, and you must do it. And then the live streaming. I have been doing a lot of live streaming. I don't recommend it. I don't know whether you want to do, you don't want to do, but I do a lot of live streaming on different platforms. It could be a Facebook Live, Insta Live, YouTube Live, and live to different conferences in the country and outside. We do a lot of aneurysm coiling, AVM embolization, carotid artery stenting, you name it, we do it live. And that gives a lot of confidence to your hospital people, because when I walk into the hospital, and we have a social media group like every other hospital WhatsApp group, when I'm doing live, I'll just put a message that I'm going to go live after half an hour, you can come and watch it. They may or may not comment on it, but they understand that this guy has the ability to perform it well, perform it in front of everybody. So that gives them a confidence that yes, he is good. So that is another technique that you must follow. So if you do all that, you become a master strategist. But most important, to be a dhurandhar, your action also has to be good. You have all the good strategy, you have got the patients right, but your operating skills are to be very good, complication rates should be low, and you should take help when it is required from your seniors. You have to upgrade your skills, know your hardwares, then definitely there is a scope for you to become a dhurandhar. So like for example, the carotid, just showing a couple of cases before I stop. I am the only speaker who has like a lot of ample of time for discussion. Good. So this is like a carotid, and then you can go ahead and you can stent it, and in multiple cases already we have seen. So this is a carotid, stent, and then balloon angioplasty. So you can create beautiful result. This is again a critical carotid, distal embolic protection, stent. You can create result bilateral. You can always do it. Jenny and all have shown excellent cases already. I don't have to go through all these cases, but this is how you can do it. Any level of difficulty you can do it. Carotid stenting is almost always possible in all the patients, 99% of the carotid artery disease that we deal with today, because of sophisticated hardware. The visual ability of this is an excellent cath lab, so we are able to do almost all carotid stentings. Thank you so much. 5 minutes. I have surplus. Jenny should have more time actually. So questions or after this?
This is last talk, so we can take any questions.
Yeah.
Also for the previous speakers also. And for, yeah.
You can give mic to the table where Gaurav, Manisha, Sailesh sir, Chinmay, everybody is sitting there. You can give some mic there also.
Hi, thank you. So I'm Tarun Sabral from London, UK. I have two questions. The first was for Dr. Sailesh. He mentioned about embolic protection and not embolic protection. In the last 15 odd years, I've stopped using embolic protection in majority of cases. And you mentioned you're going to release some data soon. I was just interested what that will be, if you can share with us.
I've just sent a publication for carotid stenting without using protection device. So this was lacking in the literature. I've tried to publish sometime back in 2009, but since I was in the US at that time, I lost all my data in India. So when the revision came, I could not complete the revision, and that time I lost the chance. But this time I have done a very systematic study over a 5-year period in a systematic manner. We have studied the, okay, this way. Okay. So we have a follow-up also, and we could study almost 150 patients, but that was sadly overlapped with the COVID period. So during COVID time, we were not getting elective stenting. That's why that 150 figure we finally got to investigate. And what we have found that despite not using carotid protection devices, our stroke rate is almost less than 4%. All composite of stroke plus MI and death. So that is less than 4%. So we have already.
Don't you think that we should be doing an MRI to see whether there are micro-infarcts which are not symptomatic, and subsequently it might cause a cognitive deficiency?
People have already done a DWI imaging in post-stenting patient, and they have found hits. What is interesting is if you do an aneurysm coiling and do WI, you will get hits. Right? If you do a diagnostic angiogram, aortic arch run, you will get hits. So the question is whether they are symptomatic or not, that's more important. So 95% of the time those hits are asymptomatic. So we don't bother much about the hits. What we bother about the patient who becomes symptomatic get a DWI done. That's the time when we do DWI. So DWI actually people have done, and they have recommended use of mesh layered stent, right? So that was one of the indication for using a layered stent.
Let's.
Okay, right.
So no, I agree with that. So my practice has changed a lot to mesh layered stents, and I don't use filters. I had a second question, for all the speakers, is I work in London where a lot of my patients come from vascular surgeons. I work together with them, luckily. They are putting pressure on getting TCAR into the system.
Last 2 minutes.
Like all you have shared, that most procedures we can do without TCAR, we hardly fail getting stents, and if we have to, we can do direct punctures, or they do carotid endarterectomies. How is the feeling here in India about TCAR? It's not yet introduced. But what's the feeling about people? You must have seen it. I mean, I don't totally believe in it. I don't buy in it. Just wanted to know what you guys think.
I'll say that this is a very, very complicated procedure for a carotid artery disease. When we can actually do a stenting in 15-20 minutes, TCAR is a very lengthy procedure, and it's a major surgical intervention. And there is no proven benefit of doing a TCAR over endarterectomy or a carotid artery stenting protected.
No, I think there is data now in America, but the surgeons are producing that data because at least in Europe and USA, it's surgical led because it's a procedure surgeons will want to do. But like you say, I think it's easy for us to do it without, and we should have data to prove that against them.
Exactly. We might have to have studies for TCAR versus the other procedure for recanalization of carotid.
Sir, you said you do without filter, right? You don't. What is your timing of carotid artery stenting? Is it like in acute phase you do it, or?
No, so I'm actually not a neurointerventionalist. I'm an interventional radiologist who does some extracranial work, but I do all the carotid stenting because nobody else in my center does it. So I don't do acute stroke. So I don't do within 14 days. It's usually the radiation strictures, atherosclerotic disease, or after 14 days. And I've moved to layer mesh stents. Majority of my stents are.
Okay, so that it makes sense.
Yes.
But in atherosclerotic acute setting, there is chance of.
No, fair enough.
Time is up.
I'd like to take advantage of the fact that there are many experienced operators over here. So I had just about complications with reference to ECA. So we have seen many times that when we do a plasty or a stenting of the ICA, you have a snowplow effect and you have causes stenosis of the ECA. Have you had any patients who tend to complain of chewing angina? I mean, what is it called?
Jaw claudication.
Yeah, jaw claudication. Sorry, yeah, jaw claudication. And another case where I recently had amaurosis with a patient who had a near occlusion of the ICA with poor intracranial flow, and ECA had taken over the ophthalmic supply. So again, in this chap, I ended up doing a postplasty of the ECA after going through the stent structure and all that. So I just want to know, how frequently do we examine, do we take any precautions?
The snowplow effect and losing the ECA on the ipsilateral side is quite common. And usually it's if the other ECA is very good, generally they develop a jaw claudication, especially when they chew for harder substance like chapati or roti. I generally tell them once ECA gets occluded that you may have jaw claudication, which is a self-limiting condition which generally takes over after 2 to 3 weeks. They generally collateralize nicely. Only the issue comes when the other side of ECA is also occluded. We had a recent case where the ICA was occluded, the other ICA was critically stenosed, and this ECA was supplying, reforming the other one. When we did a stenting on this ECA got occluded. And this other ECA was getting supply from ECA to ECA collaterals, and the patient after the procedure deteriorated. Because the contralateral ECA was dependent on the ipsilateral ECA. Ipsilateral ECA got stenosed once the plaque shifted into the ECA. In spite of using an opening cell, we were anticipating this complication. Still this happened with the open cell. We avoided dual layer stent because it may plaster, because we lose most of the ECS in dual layer stent rather than the open cell. Instead of using the open cell, we lost it, and patient developed symptoms. But there were deep watershed infarcts on the DWI. But we increased the pressure, and we kept her in the supine position, increased the pressure. We maintained that for a couple of days. Then the patient's symptom reversed, and we could salvage that case. This is a real issue when ECA is dependent on the intracranial circulation. Otherwise, we can salvage this with maintaining a good pressures, and we stopped antihypertensives. The patient was salvaged. Losing ECA with a normal other ECA is generally a benign condition.
What's your practice, Dr. Gaurav, for the carotid web? Do you do upfront stenting, or you medically manage? And
so we tend to stent rather than wait. So I think it's a definite lesion disease, so we do not see an indication to wait. So, and most often than not, they are symptomatic. You start imaging them because there is some symptom. So it's hardly on a routine health checkup that you will get to find a web. So in my experience, I think we end up stenting more. I tend to use a filter as much as possible. So we have a contrary opinion, but that's about it.
so, any more questions? So we'll conclude this session. Thank you so much. Thank you so much, all the audience and all the speakers. Thank you.